Hello, friends. I'm Dr. Sai Kumar. I'm president of the Cochin Ophthalmic Club, and we are very, very delighted to welcome all of you to the fourth edition of the PG training program, which we have called Super Sunday. It began in January. We had till March, and then April and May, due to the lockdown, there was a gap, and now we have decided to go digital because we don't know how long this lockdown is going to last. So this digital format of Super Sunday, which is the fourth edition, we are mainly focusing on cornea, and we have a galaxy of senior cornea specialists from across Kerala who will be highlighting all the important topics in cornea which is relevant for postgraduate students to all of you. So without much delay, I request the Secretary of the Cochin Ophthalmic Club, Dr. Gopal Pillai, to take over the proceedings, to introduce the speakers to the audience, and then we will get on with the talks. Dr. Gopal, please.
Thank you very much, Dr. Sai. It's indeed a pleasure to have you all back, all the postgraduates in this program. The first three editions of the Super Sunday, which is specifically designed in each particular specialty for the postgraduate training purpose. The first one was on retina. The second one was on pediatric, on cataract, and the third one was on pediatric ophthalmology. Our usual plan is to cover 360-degree of that particular topic. Like today is cornea, we will be covering all aspects of cornea, and we will have a quiz program at the end of the course, maybe after 2.5 hours of intense training is over. So I have a wonderful panelists, all the corneal specialists across Kerala, and I invite Dr. Anil Radhakrishnan, who is a senior consultant and associate professor of ophthalmology at Amrita Institute of Medical Sciences in Cornea. So I ask him to introduce the cornea panel, and all the best to all of you. Let's hope that this course gives you immense knowledge in cornea. Over to you, Anil.
Yeah, thank you, Gopal. Thank you for the opportunity. I think we'll carry on with the presentation. I'll just have a brief introduction of the panel. Our coordinator of the program is Dr. Prashob. And Prashob, as you know, is a consultant in Giridhar Hospital. He has done his post-graduation from Regional Institute, Bangalore. The first speaker for you would be Shaji Hussain, who is working in Al Salama Hospital, and he is quite known in that part of North Kerala. And he is also very savvy with computers, and he's the best person to do the talk on corneal drawing. Even though it's in the digital format, I know he'll do a good job. The second talk, an important one for the postgraduates, would be about corneal infections, more appropriately called infectious keratitis or microbial keratitis, which will be covered by our Anita Jabbar. She was in Little Farah Hospital for a long period of time. She did a fellowship in cornea in LV Prasad about 15 years ago and has been practicing cornea ever since. So she's the best person to deal with infective keratitis. Next, you have Freddie Simon, who will be dealing with corneal ectasias. Corneal ectasias, as you know, it's very common nowadays, especially with the lot of imaging techniques that we know. We pick up early cases, how best to deal with them. Dr. Freddie would talk to you. Dr. Freddie, as you know, is a senior consultant and a main person in the Dr. Tony Super Specialty Eye Hospital in Alua. Then we have Jairam, who will tell you about the treatment of ectasias. Jairam has done his post-graduation and the senior residency in cornea from RP Center, that is Already Institute of Medical Sciences. And he also has been practicing cornea and refractive surgery for the past 15 years. So he'll be telling you about the treatment of ectasias, which has a lot of confusion about it. Then you have Dr. Sujit Nayanar, who will be talking to you regarding limbal stem cell deficiency. Sujit, again, is famous in, he's working in multiple hospitals in Calicut region. And he's an exponent in the field and has been, again, practicing for about more than 10 to 15 years. Vinay will join then. Vinay would be talking on limbal stem cell deficiency and chemical injury. Basically, he's known as an ocular surface person. He was a consultant in Shankar Netralaya as well as in LV Prasada Institute. Before joining Chaitanya Hospital. Now he is working in Giridhar Eye Institute for the past 4 or 5 years. Next, you have Dr. David, who has done a fellowship again from, he has done from Arvind Eye Hospital and has been working in Little Flower Hospital, Gamali. And he'll be talking to you regarding the corneal storage media and briefly about transplantation techniques. And lastly, I would be joining in with regarding corneal graft failure and graft rejection, different types of rejection I'll be detailing. And I'm Dr. Anil, I'm working in Amrita Institute of Medical Sciences. I've been also practicing cornea for the past 18 years. So we'll go ahead with the first presentation by Dr. Shaji, basically about corneal drawing.
Hello everyone, I'm Dr. Shaji. I'm from Perindalmanna, Malappuram. I work in Al Salama Eye Hospital. I hope my screen is visible. Yeah.
Yeah, it's visible. You are very well audible.
Screen is visible, Shaji.
Okay.
Please go ahead.
Yeah, okay. So I shall proceed. So the topic, as you can see, is corneal drawings. And it all started in 1961 when Charles Louis Chopin started drawing corneal lesions in different colors, and A.J. Brown took it up to an article in 1973. And with regard to drawing in cornea, these are the colors that should come in our mind, that is black, brown, blue, yellow, and red. So to remember that, we can just imagine it as 3 bees sitting on a street, on a traffic light, which would mean the 3 bees stand blue, and the lights of this traffic lights are the other, green, yellow, and red. So to proceeding, where does each color come? This is how we can sum it up. Anything that is outside, mostly outside the cornea, are represented mainly in black. The only thing that goes in the cornea represented in black is the scar, and anything within the cornea, under the corneal surface, is usually represented as brown, depending upon the structures. And with regard to the cornea, anything above the corneal surface, just in layer with the epithelium, is in green, and few lesions represented within the corneal stroma goes in as yellow, red, and blue. So to start with the black one, best example to give would be a penetrating keratoplasty, in which the limbus represented as black, the graft post junction rim is represented in black, the sutures go in black, and if there is a loose suture, we have to encircle it. And this is a corneal foreign body, and that is represented in black. Always with regard to cornea, you should never forget that usually happens with residents is they forget to draw the cross section. So always along with the front-on view of the corneal representation, you should always mark it to know which plane of the cornea is the lesion involved in. In this case, there is a foreign body represented in black within infiltrates, which is represented in yellow. Next is another corneal scar. As I said, that is maybe the only thing that is not external to the cornea, but within the corneal stroma, which could be represented in black. Also, we should draw the cross section and say in which layer of the cornea is it, and mark it accordingly. Like in this case, this is a subepithelial scar. Now, next one, this is a contact lens. Its soft contact lenses are usually drawn in dotted lines, and in rigid lenses are drawn within the corneal plane according to their into the place where they hold on. Now, this is another thing that is told to be because of external deposits. Now, this is a dystrophic change in the cornea, which is again represented in black. And in the cross section, we should represent the plane where the dystrophies occur. Now here, this is the actual real picture with vascular infiltration and a little bit of edema. So along with the representations in black, wherever there is an edema, the stromal edemas are represented with a shaded blue, and DM folds represented in a wavy lines. And there is also a vascular infiltration, which are superficial vascular wavy lines representations encroaching onto the graft. Now this is again a representation of a desect graft, wherein, as you can see, the margin of the corneal graft is represented in the front-on view with a complete circle, and the position of the graft is represented under the endothelium, again in black. Now this is actually a corneal scar, which is along with that, which is represented in a dark shaded lines. Along with that, there are synechies, and those have to be represented in brown, which is coming under the cornea. And here you can see there is 360-degree peripheral anterior synechia along with the leukomatous scar. The representation in the cross section has to be the position of the iris, whether it is incarcerating into the cornea. Now, with regard to green, anything like an epithelial defect or epithelial erosions are represented. That is, all within the epithelial plane are represented usually in green. Now, this is an epithelial punctate erosion, told to be from a drug erosion. And in the cross section, we have to represent it, which plane, that is in the epithelial plane. Now, this is a dendritic ulcer, now which is represented in a dendritic pattern with a green color. And in the cross section, we have to represent the plane of the lesion. Now, these are multiple SPKs. With respect to erosions, the size of the SPKs are usually drawn as larger dots. And in this arrow usually represent at which area are we taking the cross section. For example, if there are multiple infiltrates with regard to yellow, that I'll be explaining later, we'll have to draw 2 arrows and represent it as 2 cross sections. Now, these are filaments. Again, we draw it as wavy lines on the corneal surface, and in the cross section also we have to draw it over the epithelial surface. Now, with regard to blue, that represents stromal edema in shaded marks. The bullae as tiny, small circles, and the larger bullae or macro bullae are represented as larger circles. In the cross section, again, we represent where the edema is existing. If there are DM folds, there will be wavy lines that will come in the division. Now, this is a case of epithelial erosion along with the representation of epithelial erosion adjacent to an area of viral keratitis. Here there is an epithelial defect, but we do not usually color the whole thing as green. We usually just mark the margin of the epithelial defect in green, and we should mention the size of the epithelial defect. Along with that, with respect to the edema, we have to draw it as blue shaded lines. Along with that, wavy lines will represent the DM folds. With respect to yellow, it indicates inflammation. So hypopyon comes in yellow, and the stromal infiltrates and the fresh KPs are represented in yellow. When there are pigmented KPs, it has to be represented in brown. Also, never forget to draw the cross sections. If there are 2 infiltrates, we are supposed to be drawing 2 cross sections, and the first arrow will represent number 1, and the second arrow will represent the area of cross sectioning in the second diagram. Now, this is a case of bacterial corneal ulcer. As you can see, there is edema, which is again in shaded blue, and the corneal infiltrates go in as yellow, and the area of desmetocele is represented with a green margin, and we should in the cross section mention how much of the cornea is thinned. For example, in this case, this is 90% thinning. Now, this is a case of fungal keratitis. As you can see, there is stromal edema being shadowed in a shaded blue. The stromal infiltrates are represented in yellow. Also, the feathery outline of the lesion is marked well, and it represents the hypopyon height. Never forget again to represent it in cross section. Now, this is an advanced case of inferior corneal thinning, probably because of secondary causes. And here we can draw the pupil in brown, the pupillary margin in brown. Along with that, the area of iris incarceration can be represented in brown. And the others, as I mentioned earlier, the DM folds, the DM edema can be represented as wavy lines, and the blue shadings represent stromal edema. Now, the superficial vessels are represented as wavy red lines. Now this is a case of anterior uveitis. That is, again, the AC cells are represented as yellow, and the pigment deposits over the lens are represented in brown. Now, structures underlying the cornea, as said, like the pigmented KPs, are represented on according to their plane of presentation. The deposits under the endothelium at the area of cross section is represented here. And in the last one is the red one. There we have to represent it as mainly the superficial vessels are as wavy lines. The deeper vessels are represented as straight lines starting just from the limbus. Hyphema is represented in red. The ghost vessels take up dotted lines, and the staining patterns, according to whichever stain we have used, we can use colors accordingly. Now, this is a summary of the different colors, that is the blue, black, brown, yellow, and green. Now, I would also like to refer you people to a very good presentation by Hilda she was a fellow in Angamali, and she has come out with a very good YouTube video on corneal drawings. I would request all PGs to go with it also. Thank you.
Dr. Shah, you finished with your presentation?
Yeah, I'm done.
Dr. Anil, can you take over?
Yeah,
Yeah,
you can.
So thank you, Shaji. It was quite illustrative. I think we have already lost a bit of time. We will go ahead with the next presentation. That's by Anita Jabbar on infectious keratitis. Anita, are you there? Shaji, can you exit this screen now? Yeah. Stop slide sharing. I think there is some problem with Anita. She's not there in line online.
No, she's there. She's very much there, Anil.
Okay.
She's there. Can you share the screen, Anita?
Is my slides visible, Gopal?
Slides are not yet visible, Anita. Yeah, now you have started share screening. Yeah, very good. Now it is visible. Make it full screen.
Okay, sure. Okay.
No, you just need to start the slideshow.
Yeah, you can just make it full screen. Perfect.
No, this, where is
okay.
my beginning, starting?
No, you can, yeah.
Okay. Okay.
Yes. Good. Start.
Okay. Thanks, Gopal, Anil, and Sai, and Prashok for this opportunity. And dear students, it is my first virtual meeting, and it is difficult to talk without seeing your faces. And so this is infectious keratitis in a summary. Actually, I have a whole lot of slides to show you, so I will be going a bit faster. Everything will be available in your text, and this presentation I have made in a more theoretical manner, but don't take it down. And everything is given in your textbooks. First, we will take the bacterial keratitis. So, bacterial keratitis are more seen in developed countries, whereas fungi is more common in developing countries. For bacterial keratitis, a predisposing factor such as a breach in the host local defense mechanism is essential. In developing nations, the most common etiology being trauma, and the most common organism being Streptococcus pneumonia and Pseudomonas, where in developed countries, contact lens is the most common etiology and the organisms being Staphylococcus and Pseudomonas. So these are the pathogenic bacteria causing infectious keratitis. Like there are different gram-positive cocci like Staph aureus epidermidis, Streptococcus pneumoniae, gram-positive bacilli like Corynebacteria, diphtheria, nocardia, and atypical mycobacteria. Gram-negative cocci are Pseudomonas, Klebsiella, Serratia, etc. Gram-negative Coccobacilli are Haemophilus and Moraxella. So, in the pathogenesis of bacterial keratitis, there is always an interplay between these three defense mechanisms. These three defense mechanisms always go hand in hand synchronously. They are the host defense mechanism, the risk factors which are intrinsic and extrinsic, and also the virulence of the organism. So let us see this flow chart. The first line of defense being the lids, lashes, your bony orbit, etc. And any predisposing factors on these areas like any lid abnormalities, proptosis, MGTs, etc. will be defecting the first line of defense. The second line of defense being your tear film microbial flora along with your malt. And the predisposing factors like Sjogren syndrome, any autoimmune disorders causing conjunctival scarring, chronic dactylic cystitis, etc. The third line of defense being intact corneal epithelium. Intact corneal epithelium is breached when all the conditions like recurrent corneal erosions, other epithelial and Bowman's dystrophies causing recurrent erosions, post-keratoplasty, post-refractive surgery, and even drug toxicity. So whenever there is a breach in the host defense mechanism, and also there are some extrinsic factors like contact lens use, trauma, conjunctivitis, etc. There will be bacterial adherents like pili and lipoteichoic acid. The pili is seen in Pseudomonas and Staphylococcus has this lipoteichoic acid. And there will be the host immunity will be active. So the inflammatory cycle and the complement mediated inflammatory cycle will be activated, causing the interleukins, TNF alpha, and causing the chemotaxis. And the bacterial toxins and these activated neutrophils from the limbal blood vessels mediates the collagenolysis, increasing the matrix metalloproteins and tissue-mediated mucoproteins, etc., causing further collagenolysis or stromal infiltration and necrosis. So that is the pathogenesis of a corneal ulcer. So, but some of the organisms can cross intact epithelium. What are they? They are the Neisseria gonorrhoeae, Listeria, Haemophilus, and Corynebacteria, diphtheria. How do the contact lens induce keratitis? Like when we give a therapeutic contact lens for a patient without using prophylactic antibiotics, it is a causative factor for keratitis. Also, when you wear extended wear contact lenses, and also there will be hypoxia, repeated microtrauma due to the contact lens, collection of debris, and close proximity to the bacterial biofilms. Common organisms in a contact lens induced keratitis means Pseudomonas aeruginosa. But Pseudomonas aeruginosa has pili and they will adhere and the organism form a biofilm preventing the penetration of antimicrobials. Trauma is common in developing countries like us. Metal, foreign bodies, soil, vegetative matter, etc. can cause corneal ulcers. In contaminated soil, foreign body, the nocardia is a common cause. Broomstick injuries, bacillus is a common cause, and following refractive surgery, atypical mycobacteria is a common cause which runs an indolent course. What are the clinical features of bacterial keratitis? There will be sudden onset of severe pain, redness, tearing, photophobia, and defective vision. And always elicit careful history. Always ask the patient whether there was any history of trauma, history of medication or contact lens use. Why medication is important? Because antimicrobials without proper use can alter the ulcer appearance and also reduce the yield of scraping. So you have to stop the antibiotics before you scraping. Signs include lid edema, blepharospasm, conjunctival congestion, chemosis, discharge, either watery or mucopurulent discharge, and also there will be an epithelial defect and a hypopion. So what are the stages of the ulcer? The stages of the ulcer are, there will be stage of progressive infiltration, like there will be an epithelial defect and increasing cellular infiltrate and edema. What you are showing in this photo is a stage of progressive infiltration. Then there will be stage of active ulceration. That is, there will be progression of epithelial defect, there will be stromal necrosis and dense suppuration, fuzzy margins surrounded by edema and a very severe AC reaction. You can see the hypopion has increased in this stage. And stage 3, upon medication, the symptoms will reduce, the resolution starts, and you can notice that the scarring has started from the edges. Always graying of the ulcer will be there from the edges. And you can see there is only a central epithelial defect and an infiltration, whereas the surrounding edges are scarring. And this is a totally scarred corneal ulcer. But if it is not treated properly, the liquefactive necrosis can continue, causing thinning, desimetocele, and perforation. All are shown in this photo. And if it is a small perforation less than 2 mm, you can do a tissue adhesive, that is cyanoacrylate glue or a fibrin glue, and put a bandage contact lens. In this photo, the AC is still shallow, but you have to form the AC nicely. Sometimes there will be rapid collagenolysis or stromal lysis leading to pseudocornea, like what is shown in this photo. And sometimes there will be extension to sclera, forming a scleral abscess. Nocardia is known to cause such complication. What are the differential diagnoses? This also we should know. Do not think that every epithelial defect and infiltration is an ulcer. There are some non-infectious causes also, like a shield ulcer of vernal keratoconjunctivitis, interstitial keratitis. It is immune mediated, it is not infected. And also in peripheral ulcerative keratitis, flick-10-la keratitis, chemical injuries, such and such a differential diagnosis of infective keratitis. Then how will you diagnose a case of infective keratitis? The use proparacaine, because proparacaine does not reduce the antimicrobial content. You should scrape from the active edges and the base. You should discard the superficial slough, because if you put the superficial slough, only the bacteria, the microorganisms won't be present. And if there is thinning, do gentle scraping. First, you smear, collect smears in the slides. Second, collect in the agar plates in C strokes. It is better to send to the microbiology department within 30 minutes of your tissue specimen collection. So what are the stains you use? Gram stain you can use. The freshly prepared KOH, 10% KOH can be used. Jeansa, seal nails and stain. Then other stains like acridine orange, etc., can be used for several for different organisms. This picture shows gram-positive cocci. This shows gram-negative rods, and this is nocardia in a modified acid-fast or quinone stain. 1% sulfuric acid is used in this way. And different special culture media are thioglycolate broth is used for anaerobes, Thea Martin for Neisseria, and Lowenstein-Jensen for mycobacteria. So for bacterial cultures, when is the culture significant? That means same organism should grow at the site of inoculation, or on 2 or more solid phase cultures. That is 2 solid cultures showing same organisms, then that is significant. Then if the smear and the culture is showing same organism, that is growth at the site of inoculation on 1 solid phase media consistent with your smear results, and if there is confluent growth on 1 media. So if there is deeper infiltration, you can do a corneal biopsy. I'm skipping, due to lack of time, I'm skipping this slow running video. And you can do a re-scraping if initially there is no yield, or even if the maximum medical therapy does not show any response. But before repeat scraping, you should give a drug holiday, like withhold the antibiotics for a minimum of 12 to 24 hours. Other diagnostic methods are PCR. PCR is not very useful in bacterial keratitis, but may help to exclude fungus. because many bacteria are forms part of normal conjunctival flora. So PCR shows a limited role only. Other tests what you do when a patient is admitted or seen in OP is you always check the patency of his duct, then corneal sensation, IOP either digitally, then ask for a systemic immunosuppression whether he is having any drugs, and also check the status of diabetes. So these are different clinical pictures. Staph aureus, this is the most common bacteria, and here you can see rapid dense infiltration like what is shown in these two photos. This is a Staph epidermidis picture. This shows this has a slow indolent course. This is a Streptococcus pneumonia. All these three pictures are Streptococcus pneumonia or pneumococcal ulcers. It shows hypopion and it shows a leading edge as well as a scarring. The one edge will be progressing and the other edge will be scarring. This Nocardia asteroids. Nocardia is a wreath-like pattern of multiple pinhead-like infiltrates, like these two photos. Then this is a non-tubercular mycobacteria or atypical mycobacteria. This patient has undergone LASIK and you can see the LASIK flap boundary and in the interface there is a cracked windshield appearance is seen in this organism. Pseudomonas has profound collagenolisis. There will be severe discharge and there will be stromal lysis and finally perforation. Serratia also, there will be pink hypopion. That is not very clear in this picture. It has a pink hypopion. And this is associated with purulent discharge, purulent hyperpurulent conjunctivitis, chemosis, and also the cornea will be just melting away. Then another condition is infectious crystalline keratopathy, that is alpha hemolytic streptococcus, ICK. ICK, you can see multiple needle-like infiltrates within the stromal. It is a deep stromal infiltrate. The clinical picture is like this. So how do you treat a bacterial ulcer? Do according to your microbiology smear. If for smear positive, then smear guided therapy is done. If it is respond to treatment is okay. If it is not responding, then check for the complaints. So first, before suspecting any change in diagnosis, first ask the patient how you are putting the drops and ask them to show the drops. And am I visible?
Yes, it is visible. Continue, Anita.
Okay.
It's visible.
Okay. And if it is not responding to treatment, then rescrape and then treat accordingly. And if it is non-healing, then any adjunct therapy is important, is needed. Otherwise, go for a therapeutic keratoplasty. These are the drugs what we are using for gram-positive organisms: fortified cephalosporin and chloramphenicol. Or broad spectrum fourth generation quinolones can be used, Moxie or Gatti or Vanco. For gram-positive bacilli, also same. First line of therapy is fourth generation quinolones. Nocardia, first line treatment is amikacin. You can also give trimethoprim and sulfamethoxazole. Non-tuberculous mycobacteria, again amikacin or clarithromycin. Gram-negative cocci, ceftazidime or Moxie or Gatti can be given. Gram-negative bacilli, Tobra or Genta or quinolones. And if it is no organism, we will give an empirical treatment. Empirical treatment can be started as either, if the ulcer is small, you can give a monotherapy with a fourth generation quinolone, or cefazolin with tobramycin or gentamicin is the empirical treatment. So guidelines is first the patient requires frequent topical drops, frequently applied, because you need higher tissue concentration, and there will say loading dose concept. Why should there be a loading dose concept? Because of the avascularity of the cornea and also due to the poor drug penetration. That means you ask the patient to sit in the OP, and every minute you apply for the first 5 minutes, every 5 minutes for the first hour, and hourly till the waking time. If there is a delay in the microbiology or if the result is negative, then go for the empirical treatment as I was telling. Oral or parenteral antibiotics shown to be no benefit, but indicated in ulcers with perforation, scleral involvement, and endophthalmitis. But in gonococcal infections, it requires systemic ceftriaxone. Review periodically. Compliance is very important. Predisposing factors also you should check, and suspect resistance if it is not healing. Reculture or rescrape, modify your therapy. But if the ulcer is healing, but still the patient is having symptoms, or patient conjunctival congestion is still on, then you suspect drug toxicity. Steroid use is controversial. This is a very famous study, the like SCUT study. Steroid and antibiotic were given. They were analyzed, and they found that no difference in best corrected visual acuity in 3 months in the steroid given group. Even if you start steroids in smear positive cases, start it after 48 hours of antibiotic use. If it is unresponsive, leading to progressive thinning and decimatocele, finally perforation, after the perforation, healing will be better because of the fresh flow of aqueous with new antibiotics. Small perforation can be dealt with tissue adhesives and bandaged contact lens, but larger perforation leads a multi-layered AMG or a therapeutic keratoplasty. So, for a persistent epithelial defect also, a tarsography is needed or a multi-layered AMG. What is the role of CXL, that is cross-linking with a UVA radiation? It showed variable results. Mechanism of action of cross-section of cross-linking is UVA has an antibacterial effect, and CXL will strengthen the collagen. And it is presently used as an adjunct in refractive cases by multi-drug resistant strains. Therapeutic PK is done for persistent ulcers if there is a large perforation, and compared to fungal keratitis, outcome of TPK is better in bacteria. Now we'll go on to fungal keratitis. Fungal keratitis, aspergillus is seen in the tropical climate. Fusarium is also seen in tropics, but Candida is seen in temperate climates. Aspergillus and Fusarium are the filamentous fungus, and Candida is the yeast. Filamentous fungus, there will be corneal aberration, particularly with the vegetable matter. Yeast, you can see in immunocompromised patients. Dimorphic fungus, it rarely affects cornea. Pathogenicity of the fungal corneal ulcers are there is direct effect on the immune system because of the steroid use or the risk factors being steroid use, persistent epithelial defect or a bandaged contact lens, neurotrophic keratitis, and diabetes. But fungal ulcers always give us poor clinical outcomes. Why? Because there is a delay in diagnosis and inappropriate use of antibiotics or steroids initially, and due to the virulence of the organism. Classification of the fungus are mainly filamentous and non-filamentous. Filamentous are again divided into septate and non-septate. Septate are divided into non-pigmented and pigmented. Non-pigmented hyaline filaments are seen in Fusarium, Aspergillus, and Acremonium. Pigmented are seen in demititious fungus like Curvularia, Lacidosplodia, etc. Non-septate are seen in Mucor, Rhizopus, Absidia. They have no corneal involvement, but they are important causes of orbital diseases and endogenous endophthalmitis. Yeast or yeast-like fungus, they are non-septate. They reproduce by budding and they form a pseudo-hyphae, but there is no mycelium like in filamentous fungus. Examples are Candida and Cryptococcus. They are seen in the skin flora and the respiratory tract and conjunctiva, and they are opportunistic pathogens. Dimorphic has two forms, yeast phase that is present in the tissue form and mycelia phase in the culture form. Their examples are blastomycosis and coccidiomycosis. Pathogenesis, there will be a trivial shearing trauma by vegetative matter, especially during this harvesting season like paddy husk, onion skin flake, etc. Then the invasiveness, why the patient, the host develop infection, that is that depends upon the load, fungal load, and the host immune response. The fungus will enter the eye. The cornea will shed their protective coat, thereby exposing the cell wall protein, and they bind to the corneal epithelial cells, and thereby more and more hyphae are formed. The hyphae will branch out to form large mycelia, and they establish their colonies there. Meanwhile, the host innate immunity is also activated. The innate immunity is activated by the pattern recognition receptors or the PRRs on the corneal epithelium. and also the PAMs in the fungus, that is pathogen-associated molecular pattern in the fungus. So the innate immunity is activated, causing inflammation by the neutrophils, macrophages, and the lymphocytes of the limbal blood vessels, and this can lead to stromal lysis and collagenolysis. Clinical features of fungus are, we all know that signs are less because the patient, the symptoms are more, but signs are less. Why this is so? Because the size of the fungus is larger, and these neutrophils cannot phagocytose rapidly and trigger off a complement cascade. The triggering of the inflammation and the complement cascade will take some time. That is why the patient has no congestion. Early stage, they may mimic a bacterial or a dendrite. These are pseudodendrites of a fungal, whereas this is a typical viral dendrite. These are more linear, but this is stalk and stubby. Then there will be the stromal infiltrate increases with the DM folds and stromal edema, and this is the hallmark feature of fungal keratitis, that is the feathery margins. Then later on, there will be a large, elevated, dirty white surface, and the ulcer surface looks very dry and rough. Later, there will be endothelial plaque with a sac-like lesion. And also, like acanthamoeba, this multiple stromal infiltrates in a ring-shaped manner is also present in fungal keratitis. And this is a Wesley's ring, that is antibody response to fungal antigen. And this the same can be seen in acanthamoeba as well as in viral infections. And in fungal keratitis, the hypopyon is not directly proportional to the size of the ulcer. Sometimes the ulcer will be small, but the hypopyon will be large and dome-shaped, like you see in these photos. And these hypopyon will be thick and immobile because these contain fungal hyphae. Then another group is the demittious fungus or the pigmented fungus. See all sorts of different colors, pigments. Some will be black to brown, some will be yellowish brown, some will be brown. And you can see this picture. These two pictures seems to be alike, no, like a demittious fungus. But here, if you carefully see, this is a iris prolapse. So these type of things also can happen underneath. When the ulcer becomes large, it is indistinguishable from bacteria, and it grows deeper and perforate. Candida can produce very localized oval plaque-like elevated lesions with well-outlined margins. Investigations are scraping, microbiology. This is a photo shows a Kimura spatula being used. If you see a plaque, then you can remove the plaque completely and send it to the microbiology. And scraping will give you a gritty or leathery feeling, and the ulcer will be attached to the base. Calcium alginate swabs can be used to increase the recovery rate. Deeper lesions require corneal biopsy. Either 10% KOH, plain KOH, or with the lactophenol cotton blue or ink can be used. And this is a plain KOH weight mount showing septate branching fungal hyphae. What do the alkali in the KOH do? They digest the cell wall protein, thereby these cell walls can be sealed. And the sensitivity of the KOH wet mount, this simple technique is 76 to 91%. Whereas gram stain will stain the protoplasm rather than the cell walls. This is a gram stain picture showing fungal hyphae. And these are fluorescent stains which can be used. Calcofluor white, this is a fabric whitener which has got affinity for cellulose and chitin. These shows blue-white fluorescence. Gradient orange has also the same role. It gives a green fluorescence. Culture can be done in Sabaros dextrose agar, potato dextrose agar, and brain heart infusion broth. One should always use fresh sheep blood or chocolate agar. What our labs are doing they are using the human blood. That is why the culture we are not getting anything. Very poor culture results we are getting from our labs because they are not using this sheep blood. They are using human blood, and human blood, as you know, it will be they will be taking all sorts of medicines. Yeast. The mycelium will take 24 to 72 hours to grow, whereas yeast will grow at 30 degrees C within 18 to 24 hours. So these are all important for your practical, because these specimens will be kept for the OSCE. Fusarium shows white color, and there will be underneath, the actual color will be seen underneath the culture plate. That is called reverse pigmentation. This is a fusarium. This is a granular appearance of a Aspergillus flavus colony. This is Aspergillus niger. Aspergillus niger, initially it will be creamy white, then upon sporulation it will get a black color, and this is a bluish colony of Aspergillus fumigatus. PCR, panfungal PCR, it is a rapid and highly sensitive test, but it gives high false positive results because of the amplification of non-pathogenic organisms. But there is a question of its availability and the cost effectiveness, so not routinely done. Then IVCM, or in vivo confocal microscopy, is another test. It is non-invasive. You can see the actual branching filaments. You can see the depth. You can see the response to treatment. But initially it was studied that different branching patterns are seen in different fungal strains. Like fusarium shows 90-degree branching and dichotomous branching in Aspergillus. But recently a study from Aravind showed that no significant difference in the branching angles of fusarium and Aspergillus. Treatment, the drawbacks we are getting in treating a fungal ulcer is most of the drugs are fungistatic in tissue concentration, and the treatment schedule is prolonged. You need treatment for many weeks, forcing the patient to stop the drugs. So the compliance is an issue. Mechanism of action of antifungals is fungal cell membrane consisting of ergosterol has a barrier function, and the ergosterol, these antifungals will act, and there is to minimize damage to the host cells. So these are the commonest polyenes what we are using: amphotericin B and natamycin. And azoles, what we are using are ketoconazole, fluconazole, itraconazole, and voriconazole. Then there are two trials like the MUT, mycotic ulcer treatment trial. It showed that natamycin is superior to voriconazole in filamentous fungus, especially fusarium. And voriconazole should not be used as a monotherapy. And in yeast, amphotericin B is the drug of choice. MUT2 trial shows systemic voriconazole, if added, there is no added benefit. And systemic voriconazole has a role in scleritis and to treat endophthalmitis. So when will you give systemic antifungals? Systemic antifungals are given in when there is a scleral involvement or when there is posterior segment involvement. Ketoconazole 200 to 600 milligram, voriconazole also 200 to 400 milligram, fluconazole can be given. Itraconazole is 200 milligram. Itraconazole is a bit costlier than the other two. 14 to 21 days, and you should monitor LFT, liver function test. Then another mode of treatment is intrastromal injections. In recalcitrant cases, intrastromal or intracameral preservative-free voriconazole or Ampho-B can be used as an adjunct therapy. As this figure shows, surrounding the lesion, you should give multiple injections, but never perforate or penetrate the cornea. Adjunct therapy in cycloplegics and anti-glaucoma. Steroids are absolutely contraindicated in fungal corneal ulcers. Then PAC-CSL is photoactivated chromophore of infectious keratitis. It is not effective in recalcitrant or deep stromal non-healing ulcers, so not recommended. Early fungal you can try, but efficacy is variable. Prognosis means it requires fungal corneal ulcers always require prolonged treatment, and there will be drug toxicity. So the conjunctival injection won't go, the epithelium won't heal, and there will be punctate epithelial erosion. All these when present, you should suspect drug toxicity. And if the patient comes with a transient hypopion, it can be a hypersensitivity or a toxic reaction. And if there is sudden onset of, if the patient comes if there is a sudden onset of lid edema, chemosis, increased corneal edema and all, bacterial contamination of the fungal medicine should be suspected and culture the medicine to give the yield. Then while doing therapeutic penetrating keratoplasty or TPK for a fungal ulcer, this point should be kept in mind. The trephine size should be 1 to 1.5 mm larger than the infiltrate size, because the fungus will expand horizontally. So you should have a more clear zone. Residual, check for residual lesions, because recurrence will start from the periphery always. Cure rate is 60 to 90%, but recurrence rate is 6 to 15%. Then another organism is Pythium insidosus. This is seen in stagnant water or soil. This is an oomycete. Oomycete will resemble fungal hyphae, but the filaments are broader and it is ribbon-like folds, and it does not have the ergosterol like a normal fungus. So ordinary antifungals is not effective in this organism. Pythium. This Pythium, the picture quality is very poor. Pythium, you can see multiple small infiltrates surrounding the main lesion, and tentacle-like things, and a plaque with a guttering. These are the characteristic features of Pythium. Multiple dot-like infiltration surrounding the main lesion, tentacle-like projections. If the patient is rapidly worsening, suspect. You should have a high index of suspicion for this organism. Potassium iodide H2SO4 stain, take a blue stain. Growth is flat, feathery, colorless or light brown colonies. PCR can help in a rapid diagnosis. They lack ergosterol, so respond poorly to the ordinary antifungals, but susceptible to antibiotics like linezolid. Linezolid, tetracycline, azithromycin systemic, etc. are used for this Pythium. After TPK, there is a high chance of recurrence. Next organism is Acanthamoeba. Acanthamoeba is a free-living protozoa seen in soil, ponds, lakes, tap water, swimming pools, etc. In immunocompetent patients, Acanthamoeba can cause a keratitis, while in immunocompromised patients, it can cause chronic granulomatous meningitis. Contact lens wear is a risk factor. Even though it is told that contact lens wear is known to cause Acanthamoeba, but less than 5% of contact lens keratitis is due to this. Many of the contact lens induced keratitis are due to Pseudomonas. 8 species of Acanthamoeba are known. Important to us are Castellani and Polyphagy. It has 2 forms, mobile trophozoite, which is larger, and a polygonal double-walled cyst, which is smaller. Trophozoite has finger-like projections called acanthopodia. Acanthopodia, and these trophozoites feed on the bacteria. Their main food is the bacteria, and they will multiply by mitosis. And cystic form is found in unfavorable conditions, when there is no nutrition, when there is extreme temperature or pH variations, and amibicidal drugs, resistant to antibiotics, chlorination, etc. These cysts are resistant to antibiotics and chlorination, and the cystic form will remain dormant to cause a reinfection. And this is another terminology called endosymbiosis, that is intracellular carrier. It acts as an intracellular carrier to many obligate bacteria. So that increases the pathogenicity of Acanthamoeba. Risk factors are CL wear, poor contact lens hygiene, exposure to brackish water, that is washing eyes with pond or field water following trauma. It is also seen following LASIK or PRK. Pathogenesis, when there is a break in epithelium, the Acanthamoeba, with the help of Acanthopodia, will adhere to the corneal epithelium. And the corneal epithelium will desquam it, and thereby the organism will penetrate the Bowman's membrane. And there will be secretion of matrix metalloproteins, elastase, etc., causing collagenolysis, stromal degradation, and deeper penetration. Then another thing you can see in Acanthamoeba is perineuritis. The trophozoites has a chemotactic response to the neuronal cells, so they cluster around the corneal nerves. With treatment, the trophozoite is converted into cyst, and the cyst remain dormant, then later on causing reactivation. Severe pain out of proportion is a clinical feature, is a typical feature. Symptoms like redness, photophobia, tearing and all can be seen. Always suspect Acanthamoeba in a non-healing corneal ulcer or any atypical presentation. Early case of epithelial disease, it can present like a dendrite, but these are all radial perineuritis can be seen in this picture. Then after that, these stromal infiltrates will be in a ring-like pattern. This is a pathognomonic thing of, but this is not unique for Acanthamoeba. This is seen in fungal keratitis also. Satellite rings and immune rings, etc. can be seen. Complications, if not treated well, leads to episcleritis, limbitis, scleritis, and choroiditis. This is mainly picked up by the in vivo confocal microscopy. Trophozoites and cyst can be seen. This is bean-shaped trophozoid can be seen. PCR also can identify amoebic DNA. Culture is a gold standard. So what is the culture we are using is non-nutrient agar. Non-nutrient agar prevents the bacterial overgrowth. That is why we are using non-nutrient agar. But the acanthamoeba needs food. So this non-nutrient agar is inoculated at the center by E. coli or Enterobacter. So that the amoeba will feed on the bacteria and they will migrate to the periphery, leaving behind trails. And these trails can be seen under light microscopy. Culture take 1 to 2 weeks to grow. Deeper lesions require biopsy. Also culture the contact lens solution to isolate the organism. These are the culture NNA with the E. coli overlay showing trophozoites and cyst. Treatment also needs months of treatment. Topical treatment active in both trophozoites and cyst can be used. These are the biguanides like polyhexamethylene biguanide or chlorhexidine. Are the biguanides. These are cationic disinfectants which can damage the cell membrane and cell components. These are highly cysticidal but less epitheliotoxic. Then propamidine also can be used. Neomycin should not be used as a monotherapy. Use of steroids in acanthamoeba is controversial because this can be converted. Trophozoites can be converted into cyst and the cyst will remain dormant. Epithelial debridement also can be done because it helps in drug penetration and complete removal of the organism in the epithelial stage. In impending perforation or non-healing ulcers, consider a therapeutic keratoplasty. DALK or deep anterior lamellar keratoplasty is found to be effective because acanthamoeba seldom crosses the Descemet's membrane. That is why the rationale of doing the DALK. Role of CXL is not fully elucidated in acanthamoeba. Viral keratitis, most common in the developed nations. DNA as well as RNA viruses are there. 8 HSV, the herpes simplex viruses, 8 strains are there. Of this, HSV1 is the commonest. It is endemic to human. Human is the only reservoir. Predominantly, it causes unilateral versus adenoviral causes bilateral keratoconjunctivitis. But bilateral also can happen in immunocompromised patients. HSV1 cause oral infection in the upper part of the body. HSV2 causes genital infection in the lower part of the body and it is an STD. Ocular herpes is mainly caused by HSV1, but infrequently HSV2 also causes, especially in neonates while they passes through the birth canal. And HSV genome can code for 50 to 75 different proteins. That is why different strains have different clinical pattern, dendrites and all can have unequal, different lengths. After entry, they replicate at the peripheral site like eye, skin and mucosa, but they spread to the axonal terminals of the sensory neurons and they enter the neuronal bodies and the sensory and autonomic ganglia and they lie latent in the trigeminal ganglion. This is the latency is very important. The latency is due to this latency associated transcriptase. But even though it hosts in the remain latent in the neurons, it does not damage neurons. But there will be intermittent shedding through tear or saliva. And transmission is by direct contact with the tear or saliva or fomites. Asymptomatic virus shedding carrier also will be there. Primary infection, most of the patients won't even remember because it happens early in their life. Major site is corneal epithelium and through small cuts or aberrations of the oral mucosa, the virus will enter. Iatrogeny can also happen through contaminated Schott tonometers. Reactivation of the virus occurs when there is UV exposure, fever, stress, menstruation, hormonal changes, trauma, LASIK, etc. All surgeries. When there is reactivation, the antigrade transport can happen from the ganglia. It reaches the peripheral sites and causes replication. This primary can happen in children, especially in non-immune. Symptoms are fever, malaise, blepharospasm. conjunctivitis will be follicular in a non-epidemic. When there is a non-epidemic time with there is a follicular conjunctivitis, suspect HSV. Redness, smottering, discharge, swelling, pain, photophobia. Sometimes vesicles on the lids will be present, like what is seen in this photo. Cornea, there are fine or coarse epithelial punctate keratitis. There will be the mild course of over 10 days. But in it will be life-threatening in newborn or immunocompromised individuals. Recurrence can happen 20% after 20 years, 40% after 5 years, or 63% after 20 years. Infectious epithelial keratitis. These are the earliest stage. This is very difficult to pick up in the early stage. But what we commonly see is the dendrite. So dendrite contains live virus and it is infectious. So never give steroids at this stage. That is why it is called infectious and it contains live virus. This is linear with the raised edges and the base will be stained by fluorescein. And these swollen, the linear dendritic picture will have knobby ends and these swollen epithelial cells contain live virus. And these coalesce to form geographic ulcer. Geographic ulcer has also irregular border, unlike a neurotrophic ulcer. Neurotrophic ulcer has got a smooth border. Epithelial lesions will often heal without scars, but sometimes they will leave some fine scars, like these are called footprint scars or ghost figures. So when the patient comes years later, search for footprint scars to give a clue to the diagnosis. And another uncommon manifestation is a marginal keratitis. So marginal keratitis is like this. There is no lucid interval, and this will be like a dendrite will be spreading towards the center with a leash of blood vessels. And this is important to distinguish from the other lesion like staphylococcal marginal keratitis. The HSV marginal keratitis contains active virus and it is infectious, whereas staphylococcal marginal keratitis is immune mediated. And there will be associated lid signs like blepharitis, etc. And the location is also different, like it was seen in 2 o'clock, 4 o'clock, 8 and 10 o'clock at the point of contact of the lids. Neurotrophic keratitis, there will be damage to the sensory cornea. And neurotrophic keratitis has a long indolent course. There will be persistent epithelial defect and the defect will be oval with heaped up borders. Stromal keratitis are two types, necrotizing and non-necrotizing. Necrotizing stromal keratitis will mimic a bacterial ulcer. This is a necrotizing stromal keratitis. While immune stromal keratitis, it is a type 3 hypersensitivity reaction. The lesion will be single or multiple with a superficial or deep stromal vessels. So take a meticulous history, look for footprint scars. And this is due to the retained viral antigen triggering the antigen antibody complement reaction.
Anita?
Yeah, a few more slides only. I'll.
Anita, am I audible?
Yes, yes.
Yeah, okay. Yeah, I think we spent quite a bit of time. I think it's okay. Can you summarize within?
Okay, I'll just summarize the treatment of viral and then stop. So the treatment of epithelial keratitis is gentle debridement and acyclovir eye ointment and cycloplegics. Neurotrophic keratitis, judicious withdrawal of unwanted drugs, give preservative-free lubricants and substitute with collagenase inhibitors. Refractory cases, you can do a tarsography, bandage, contact lens, there is a risk of infection, amniotic membrane grafting can be considered. Immune stromal keratitis, topical steroids are given to control inflammation. Concurrent antiviral therapy, if there is epithelial disease, do not give steroids. Necrotizing stromal, mild cases you can give steroids and it is slowly tapered over months. Oral acyclovir, it is given for severe diffuse endothelitis, herpetic iridocyclitis in immunocompromised patients and also in prophylaxis, in post-PK and in recurrent epithelial keratitis. So these are the drugs which are available, acyclovir, famciclovir and valacyclovir. This is a herpetic eye disease study. this is the final slide what I am showing. In HSV stromal keratitis, you can give steroids can be given, and it gives a faster resolution. In oral acyclovir has no role, whereas in HSV iridocyclitis, oral acyclovir can reduce the treatment failures. Adenoviral conjunctivitis, you all know there is follicles and subconjunctival hemorrhages are the hallmark, and you can see these stubborn subepithelial keratitis, and it is very difficult to treat. If it is in the central cornea, give judiciously use steroids.
Yeah, thank
Thanks
you.
for the time. Overshoot.
Yeah, thank you, Anita, for the excellent talk. It was very exhaustive. I think the bacterial and fungal keratitis was taken in great detail. I'm sorry I had to intervene in between, so that we have to keep a tab on the timing also. So our next speaker would be, I think, Dr. Freddy. He's going to talk on, corneal ectasias. He's going to talk on corneal ectasias, which will be followed by Dr. Jayaram, who would be covering the treatment aspect of corneal ectasia.
Good afternoon, everyone. I want to thank COC, Sai, Gopal, and Anil for having me here. Okay, I'm just going to give a brief overview of corneal ectasias. These are the topics I've been asked to talk about: something about the idiopathic pathogenesis, risk factors, when to suspect corneal ectasia, clinical diagnosis, diagnostic tools, and classification. But what is corneal ectasia? See, the definitions when we studied was slightly different, where we said progressive thinning conditions without inflammation. But now that's not, we know it's not perfectly true. So the recent classification given by the Pan American group, they gave as progressive thinning conditions without acute stromal inflammation. So they've given only 3 conditions under these: keratoconus, pellucid marginalization, 4 conditions, keratoglobus, and ectasia post-surgery. Other conditions like Terians, Murans, and Staphyloma are all not considered ectatic diseases. They're called corneal thinning diseases. And the difference between the 3 main conditions, pellucid, keratoconus, and keratoglobus, is where the thinning is. We know the keratoconus is paracentral, while in the pellucid is 1 to 2 millimeters from the limbus. And in keratoglobus is generalized thinning, more so in the periphery than in the center. Well, there's a definition of keratoconus given by the global consensus on keratoconus and ectatic corneal diseases. This is a group which met and decided a lot of things about keratoconus, and they agreed that there should be some posterior ectasia, abnormal corneal thickness distribution, and clinically non-inflammatory corneal thinning. There is some controversy regarding these, but we won't go into that. So what is etiopathogenesis? It's multifactorial, we know. The factors involved are environmental, biomechanical, genetic, and biochemical factors. And this it affects mainly the epithelium, the bowmans, and the stroma. And a few things we should know is a lot of proteoglycans are there in the stroma, which is like decorin, biglycan, lumican, ketocan, osteoglycan. All these are reduced in keratoconus. So what are changes in keratoconus? You see in pathology, in epithelium, the cells are elongated and spindle shaped. The wing cell layer has a larger irregular shaped nuclei, and the basal cell shows variable sizes. The Bowman cells is usually distorted, and usually it is infiltrated either through the epithelium from front or from keratocytes or collagen from below, from the stroma. Stroma is degraded stroma, poorly differentiated keratocytes, decrease in the keratocyte intensity. Etiopathogenesis is still not clear, but what we know is a decrease in collagen. This could be due to a decrease in proteoglycans that interact with the collagen, giving that gives mechanical strength to the cornea. or a decrease in TGF-beta, which helps in the production of these proteoglycans. Then the other theory is the oxidants and antioxidants theory. This is found favor because the ratio of the pyruvate and lactate was found to be elevated, and elevated catalase RNA was found, which again is supposed to dispose excessive hydrogen peroxide. The other things they think there's more proteolytic enzymes and reducing the inhibitors. Increase in the proteolytic enzymes like cathepsins and MMPs were found, and decrease in proteinase inhibitors like alpha-1 proteinase inhibitors. There's an inflammatory role also. There's increase found in the inflammatory mediators like interleukin-1, an increase in inflammatory cytokines like IL-17 and IL-6. These are the various genes that has gone with each from different countries. So no fixed one gene has been found. So what are the risk factors? This is again from the global consensus of keratoconus and ectatic diseases. They sat down and described these are the risk factors: Down syndrome, relatives of affected patients, especially if they are young. So it's important to ask the history of running in the family. Ocular allergy, ethnic factors is more common in Asians and Arabians. Mechanical factors like eye rubbing, then factors like floppy eye syndrome, atopy, connective tissue disorders like Marfan's, Ehlers-Danlos, and Leber's congenital amaurosis. So when you suspect keratoconus, usually the patient comes to us in the second or third decade of life. It can come earlier or come later, but usually it's just the vast majority of the patients come. Slightly earlier with a keratoglobus and slightly later with a PMD. Ocular history, usually they come with unstable refraction. They're not very happy with their glasses. They say night driving or night vision is even more difficult. If it's ectasia, they have a history of laser surgery. And some of them give a history of allergy. A lot of them give a history of allergy and rubbing of the eyes. Medical history, you need to ask for atopy, asthma, systemic associations. And family history, well, the CLEK study showed a 14% family history. So it can run in families. So if you're a refractionist, you suspect it when there's instability of refractive error. You've seen within a few months, the refractive error has changed. There's a progressive increase in astigmatism. There's inability to correct to 6.6. That's very important. Sometimes you see there, you can correct only maximum to 6.9 or 6.6 partial. Then you should suspect keratoconus. And this is a reflexive retinoscopy. When you do an external examination, all these signs are usually seen in more advanced cases. You see outward bowing of the lower lid margin when they look down. The lid might show some form of atopy. Papillary reactions, you feel an oil droplet seeing distant direct, and the Rasuti sign, the light is shown from the temporal limbus, the bright reflex is seen in the nasal limbus. So this is the Munson sign, this is the Rasuti sign, and this is the oil droplet. The clinical diagnosis, again, in most cases, early cases, we don't find anything clinically on slit lamp. We often tend to miss early keratoconus. But once it's advanced, you get finds like epithelial scarring, Leischer's ring, subepithelial scarring, thinning of the stroma, protrusion of the cornea, prominent nerves, Wolff striae, and deep scar from hydrops, so previous hydrops. So epithelial scarring, you can see the two main causes for epithelial scarring are from using flat-fitting contact lens, RGP lenses for a long period of time and usually overusage of the lens. Or the subepithelial scarring is seen in breaks of the Bowman's layer and then filling it up with connective tissue or epithelium. This you can see the subepithelial scarring in this case. Leischer's rings are hemosiderin development. You can see the ring there, seen in around 50% of the cases. These are hemosiderin deposits in the deep epithelial layers. It usually starts in the lower part, and occasionally you can see a complete ring. It's said to be more easily identified with the cobalt blue filter, but I find it even more difficult with the cobalt blue filter. Thinning and protrusion, again in advanced cases. In keratoconus, you see the protrusion is in the area of the maximum thinning, while in PMD, the protrusion is in the area of above the thinning. This is a case of keratoconus. You can see thinned out and protruded area. But this is a PMD. You can see the thinned out area is there. The protrusion is just above. Vogt striae are deep stromal stress lines. They are small, vertical, oblique, and brush-like lines you can see there. If you apply some gentle pressure on the globe, these might disappear. The scars from eye drops. Eye drops, we know, is the breakage of the Descemet's membrane and inflow of fluid into it. When it heals, it can leave with a scar in the deep stroma and Descemet's. So what are the investigations? The investigations that are used are keratometry, corneal topography and tomography, anterior segment OCT, and ocular response analyzer. So I will just go something with topography and tomography. Because keratometry, we know only in advanced cases the sender is involved, so you may not pick up cases with just keratometry. Anterior segment OCT also, initial cases you may not be able to pick up, but you can get thickness of the retina, you can pick up Descemet's stairs and things like that. And with ocular response analyzers and COCs, the biomechanics, the problem with these are in advanced cases you can see a decrease in the values, but in early cases, the normal and the early cases might give similar values. So when you use a placido base or an axial scan in a tomography, what things are you looking for? One, you're looking for a central, these are the Rabinowitz criteria. One, you're looking for central corneal power, which is more than 47.2. Inferior, superior, that means inferiors, if it's more than 1.4 diopter, then the similar point superiorly, it's significant. If the superior steepening, it should be 2.5 diopters more than the inferior similar point. And if you have an astigmatism of more than 1.5 and skewed radial axis of more than 23 degrees. Other things you look in axial map or placido-based topographies, different patterns, which shows that it could be keratoconus, like inferior steepening without a bow tie, asymmetric bow tie, central steepening imposed on a bow tie, or symmetrical bow tie with skewed deviation. So this you can see an inferior steepening, and this you can see an asymmetric bow tie, and there's some skew deviation here in this axis. And this is a central steepening imposed on a bow tie, and this is a huge skew deviation. You can see this is more than 22 degrees. Another thing which is useful in pachymetry, in placido-based pachymetry, is the Kisa index. So that looks into all these factors, and if it's 100 or more, it's clinically diagnosed keratoconus. And between 60 to 100, keratoconus suspect. If you go to topography, I won't look at the axial map, because axial map is going to be similar to the placido-based. We just look at the elevations, the pachymetry map, and the other programs which are useful for us. In the elevation maps, what you look for is in the central 5 millimeter zone, there should not be an elevated area in the anterior elevation of 12 micrometer or more, and posterior elevation 15 micrometer more. You should not see isolated islands, even if it is less than this. You see isolated islands or tongue-shaped extensions of elevation, you should be suspicious. This you can see, it's an anterior map, elevation map. You can see an elevation of more than 15. More than 12, and this is a posterior elevation map, both these, and you can see significantly elevated in these cases. In pachymetry, what we look for, one is the thinnest pachymetry. Then we should look for, there should not be a 30 micron difference between the superior and inferior part, similar points. And between the two eyes, again, there should not be more than a 30 micron difference between the pachymetry. And the thing you should look for, another thing is the displacement of the thinnest point from the center. And in PMD, you look for a band of thinning inferiorly. And this you can see is a typical keratoconus with thinning, and it's easy to pick up. But if you see this case, you can see that the thickness is 565, it's very good thickness. But you can see this is a center and this is the thinnest point. See, the amount of displacement is very high. And if you look at similar points, here 620 and here's 560. So there's around 60 microns difference. So other features are in tomography. The two is the Bellin-Ambrosiev scale, which looked into 5 factors. It basically looks into deviation from normal, of front deviation, back deviation, pachymetric progression, the thickness, and the asymmetry of the thinnest point. and they give you values which is within 1.6 to 2.6 is suspicious. More than 2.6 is seen as red. Another interesting thing which has come is in the Galilei tomography, just an automated detection program for subclinical keratoconus. This looks into 56 parameters from topography, elevation maps, tachymetry, and wavefront, and supposed to have 93.7% sensitivity and 97% specificity. So it takes the job off from us. So it will be easier to interpret, pick up early keratoconus. This is a Bell-Ambrosio scale, and these are all the differentiating factors. You can see the posterior elevation is elevated in spite of everything else being quite normal. This is another map which we found quite useful in the Pentacam which we have. Is the holiday report. The advantage is they give 6 maps, and it has a tangential curvature map which is useful when you're planning treatment. Condition you should, whenever we see a crab claw appearance, we tend to say in quiz as a PMD, but you should understand that pellucid-like keratoconus is a condition where you can have a crab claw appearance but still is keratoconus. The way you differentiate this is by looking at the pachymetry map. See, this it's a typical crab claw appearance, but if you look at the pachymetry map, you see just a paracentric thinning, and this is not a pellucid marginal degeneration. In pellucid marginal degeneration, you get a band of paracentral thinning, and you get appearance like this. It's called the Bell sign. The classification of keratoconus. This is the old classification, the Amsler-Krumig classification. This is based on the astigmatism, the refractive error, and the thickness. It has nothing to do with pachymetry, and is classified grade 1 to 4. And this is the newer classification. This is then the Pentacam. This is classified based on the anterior curvature, posterior curvature, thinnest pachymetry, the best corrective visual acuity, and scarring. And need to grade that. If you take the Pentacam keratoconus staging, if you look here, it is already graded. It's A2, B2, and C0 because it is thick enough. And D is not mentioned because we haven't entered the visual acuity. Another thing we are worried about ectasia is progression of ectasia. So, and we tend to use maximum the keratometry to look for progression. But according to the Globus consensus, they said you should look at steepening of the anterior corneal surface, steepening of the posterior corneal surface, and thinning or change in the thickness from the periphery to the thinnest point. These are the 3 things you should look, and they haven't given any values because they say it varies with the machine you use. So that's the end of my talk. Thank you. Anil. Yeah. Gopal, I'm done. The next speaker can take
it. Dr. Freddy.
I think.
So who is next? Anil? Yeah.
Yeah, next would be Jairam. Jairam would be talking on corneal ectasias management.
In between, I would just want to announce that the results of the quiz prelims will be announced in about an hour's time.
Okay.
The quiz prelims results are getting collated. It will be announced shortly.
Yeah.
Okay, Jairam.
Yeah. Okay. I will be. I'll sharing this one.
Jairam, please be louder. And for all the postgraduates who are hearing this, if you have any doubts or something like that, you chat. You basically type it onto your YouTube screen. You can just chat. Live chat will be there, and those questions can be taken up by the faculty at the end of the session.
Yeah. Thank you, Gopal and Dr. Anil.
Jairam, be a little louder.
Can you hear now?
Yeah, correct.
Yeah. I'll be talking regarding the treatment of corneal ectasias. Dr. Freddy has already nicely explained the etiopathogenesis and investigations of ectatic disorders of cornea. So it is a very vast topic. I will summarize it into the 15 minutes which I am allotted. So corneal ectasias, according to a newer classification, are basically these four: keratoconus, pellucid margin degeneration, keratoglobus, and post-refractive surgery progressive corneal ectasia. So regarding the classification and treatments, there is a whole lot of data available. So I would like all the postgraduates to at least go through this global consensus on keratoconus and ectatic diseases, which is a Delphi panel kind of initiative, which is done in 2015, which is already mentioned by Dr. Freddy. It is published in Cornea in 2015, and it's already very well available in the net. So this will give a gross idea of or a basic framework of how to go about in the basically the diagnosis and treatment of keratoconus, ectatic diseases basically. So there were three panels, one for the definition and diagnosis, and one for non-surgical management and surgical management. So all the panel were experts in the field. You can see the panelists. And I will just briefly go through that before going into the rest of my presentation. So in this, the agreements reached in the non-surgical management panel, the most important goal of management are halting the disease progression and visual rehabilitation. These are the two things you should remember. So keratoconus, the progression should be halted, and then visual rehabilitation. So recently we have with the advent of collagen cross-linking, we have the option of halting the progression of this disease, which was not available before that. And in always during the there should be a verbal guidance should be given to patients regarding the importance of not rubbing one's eyes, use of anti-allergic medications, and antihistaminics and lubricant eye drops. And they have found that there is no direct relationship between keratoconus and dry eye. And always a subjective refraction should be attempted in all patients with corneal ectasia, and aberrometry may help in determining the optical correction in early disease. And contact and scleral lenses are extremely important for visual rehabilitation in patients with keratoconus and other corneal ectasias. Although contact lens does not slow or halt the progression of ectasias, it is extremely useful in giving the visual rehabilitation. And a careful evaluation of keratoconus is strongly recommended in patients with Down syndrome and should be considered in patients with known risk factors for developing keratoconus. And pregnancy could contribute to acceleration and progression of ectasia. So patients should be warned that keratoconus patients during pregnancy, it can aggravate. In acute eye drops, non-surgical management, that is injection of air or non-expansile gases like SF6 or C3F8 should be attempted before going in for keratoplasty. So coming to the surgical approaches based on the different case scenarios, in young patients less than 15 years old with stable keratoconus, prescribe only glasses and then do a 6-monthly follow-up to look for any progression. If young patient has progression, then perform collagen cross-linking and then prescribe glasses or contact lenses. In older patients with stable keratoconus, the same way, prescribe glass or contact lens. And if it's progressive, then go for cross-linking and then go for glasses or contact lenses. But in a patient with stable keratoconus with unsatisfactory vision with glass, but satisfactory vision with rigid contact lens and tolerates them well, and has a spherical equivalent of moderate myopia, that is 5 diopters, prescribe contact lens, including squirrel lenses. Same way, up to 15 diopters, you can give contact lens. Now coming to the patient with stable keratoconus who cannot tolerate contact lenses, who have moderate myopia, perform a DALC and consider intracorneal ring implants with adequate corneal thickness, and if the patient is having adequate corneal thickness and minimal or no scarring. In patients with high myopia, also you can go with the same treatment. Patient with severe keratoconus with unsatisfactory vision with glass and contact lenses, which has a moderate anterior corneal scarring but no evidence to previous high drops, you can go for deep anterior lamellar keratoplasty. If there is significant corneal scarring and there is previous history of high drops, then go for a PK alone or attempt DALC and then intraoperatively, if it is not possible, convert to penetrating keratoplasty. So this is being mentioned in this flow chart, the same thing. And these are the modalities which are available for us, that is spectacles, contact lenses, collagen cross-linking, phakic implants, intracorneal ring segments, and keratoplasty. So Dr. Freddy has already mentioned all the newer classification systems, including the newer ABCD system, KISA index and all. But this is an old classification, but is simple. It is not topography based, but you can very well remember it and use in your clinical practice. You can, when you read a topography, then you can add upon that and make and use it for interpreting the or deciding on treatment. But this Amsler-Krumig classification is simple, and you can remember and use it in your case sheets. Always when you see a patient, try to classify and write it in your case sheet or in the patient sheet. So in this, it is simple. The first 3 stages are like grade stage 1. There is low myopia with astigmatism less than 5 diopters, with mean central reading of less than 48 diopters. In stage 2 is 5 to 8 diopters of myopia and mean K reading less than 53. Absence of scarring, corneal thickness is more than 400 microns. So these patients are good candidates for cross-linking. And in stage 3, it is 8 to 10 diopters of myopia, K reading more than 53, absence of scarring. The corneal thickness has come down. So less than 400 microns when you go, you can go for epion or hypoosmolar type of corneal collagen cross-linking. But you should decide on that, I think, on the keeping in mind other factors also. In stage 4, there is corneal scarring and it's very high keratometry values, and thickness is very less than 200 microns. So spectacles are possible only in mild cases, difficult to achieve satisfactory vision due to regular astigmatism and high anisometropia. In very mild cases, you can go ahead with the spectacles. In contact lenses, depends on the stage of keratoconus. You can use, in mild cases, soft and soft torics are sometimes tolerated. In advanced cases, you can go for specialized lenses, Rose-K, Scarasoft, mini scleral and scleral lenses. Then there is intracorneal ring segments, which flattens the central cornea and improve the central visual outcomes. Kera rings and index are available here in India. The selection of ring depends on refractive error and corneal thickness and keratometric values. Small ring segments cause more flattening. We can use either mechanical keratomes or femtolasers for creation of channels for inserting the ring segments. So these are the different types of ring segments available. And this is one more thing you should put your attention to. When you are following up the patient, this criteria can be used to assess the progression which is being used in the different cross-linking trials. So these are different refractive and keratometric indices which you can use to assess the progression of the disease, which is very important in deciding the treatment. So the keratometry into different timelines should be more than 1 diopters change. Flattest keratometry more than 1 diopter. Mean keratometry 0.75 diopters. Corneal apex power more than 1 diopter increase from baseline. Manifest spherical equivalent more than 0.5 diopters. Central corneal thickness more than 2% decrease from baseline. So this, if any of the two are there, then you can fairly assume that there is progression and decide on treatment accordingly. So coming to corneal collagen cross-linking, it was introduced in 1990s, led to significant decrease in number of keratoplasties after that, strengthens the corneal tissue and arrests progression. Riboflavin and UVA light is used in this treatment, which riboflavin plays the role of photosensitizer in the photopolymerization process. When combined with UVA radiation, increases the formation of intrafibrillary and interfibrillary carbonyl-based collagen covalent bonding, making the cornea much stronger. So this is the basic Dresden protocol. That is the removal of the central 8 to 10 millimeters of central epithelium, application of riboflavin solution 0.1% and 20% extran, the corneal surface for 30 minutes before radiation, and 5 minutes intervals during the course of 30 minutes exposure of 370 nanometer UVA. The points to consider in corneal cross-linking is corneal thickness of at least 400 microns is should be there to consider it safe for doing the procedure. It should be noted that corneal thickness measurement should be attained after epithelial removal and prior to application of riboflavin and UVA light in order to prevent the toxicity to endothelium. So after removing the epithelium, there should be 400 microns of tissue available. The use of hypoosmolar riboflavin is indicated in patients with borderline corneal thickness to sell the tissue, though there are some concerns about increased endothelial toxicity and reduced treatment efficacy. Majority of complications arise from epithelial debridement. That is, includes infection, sterile infiltrates, delayed reepithelialization of the apex of the cornea, corneal edema, and increased corneal haze. So now accelerated cross-linking is also available. Accelerated cross-linking using higher irradiance to shorten the amount of time necessary to deliver the equivalent total energy dose in a new alternative. This technique is based on Bunsen-Roscoe law of photochemical reciprocity. Some same photochemical effect can be achieved by delivering a similar total energy over a shorter period of time. The newer cross-linking machines have this options available up to instead of 30 minutes, up to 3 minutes, you can select the time according to, if you take 3 minutes, then the amount of irradiance will be more. First, you will have to put the riboflavin, soak the cornea, then delivery time of the UVA will be can be decreased. But in experience, up to 10 minutes is okay. Less than 10 minutes, it depends on the experience, your experience with the machine. According to my experience, it is up to 10 minutes, it's okay. After that, the results are not so consistent. So these are the different randomized control trials with the accelerated cross-linking versus Dresden protocol, which all of them show kind of most of them show no significant difference in visual acuity and topographic criteria. Some say which has the accelerated cross-linking is better. But in my experience, up to 10 minutes, it will give the similar effect as the Dresden's protocol. Now coming to the CXL plus, that is collagen cross-linking can be combined with the excimer laser, phakic implant, or intracorneal range segment implantation for the improvement in visual acuity. So you can either do topo-guided for PRK along with the collagen cross-linking, or sequentially. Phakic or IOL implant can also be done after cross-linking, or in stable corneas without much of a irregular stigmatism, which has a more refractive spherical component with a central cone. You can right away implant a phakic implant, posterior chamber phakic implant, giving a much better visual acuity. And intracorneal ring segments can also be done in patients with the moderate keratoconus to decrease the corneal flattening, central corneal steepening. Now coming to the surgical treatment, deep anterior lamellar keratoplasty is nowadays considered more of a treatment of choice for keratoconus, advanced keratoconus. Mainly, it is indicated in grade 4 type of stage 4 with the minimal corneal scarring and corneal thickness much less than 300 microns. The contraindications are significant endothelial dysfunction. Relative contraindications are epithelial dysfunction, limbal stem cell deficiency states, and chronic surface disease. The advantages of DALC over penetrating keratoplasty is better long graft survival, better strength, minimal steroid-related complications, easier follow-up. The low quality of donor cornea can also be used, which cannot be used in penetrating keratoplasty, which you know the very good cornea. Allows larger graft when needed without risking rejection, and minimizes suture and wound-induced astigmatism, avoids positive pressure, and is associated with lower incidence of suprachoroidal hemorrhage. Disadvantages are surgical difficulty and optical effect of the interface. So there are a lot of studies which has compared penetrating keratoplasty with deep anterior lamellar keratoplasty, which definitely shows the advantage of less amount of rejection and some advantage in refractive outcomes. These are the surgical instruments and preoperative considerations in deep anterior lamellar keratoplasty. The most adopted DAL techniques are peeling of hydrodissection, layer by layer dissection. A big bubble technique by Anwar is the now the most widely used and the better technique. This is a video showing the same. This is not a keratoconus patient. This is a corneal dystrophy patient I did recently, but the techniques are almost the same except in the initial part, because in keratoconus the cornea will be thin. You should be careful while refining. And this is a suction refine, which is marked initially, and that refine is slightly withdrawn outward before fixing. The suction is applied. Then you go into a depth of around, according to the corneal pachymetry, you go to about 242 microns depth. Usually in this refine, 1/4 of rotation will give a 60 microns penetration. Then you go for the superior lamellar dissection. In keratoconus, should be very careful when you go towards the center of the thinner portions. There is a more chance of getting perforated. After you remove the superficial part, you go for the big bubble. You penetrate with a 30 gauge needle, go towards the center and inject air. You can see the big bubble forming, and then you can see a snap and one more bubble coming. That is the type 2 bubble. So first the type 1 bubble you can see on the right hand side. You can see a very faint this thing on the bubble on the left side also. That is the type 2 bubble. So I have started dissecting and going into the interface in the type 1 bubble, and then dividing the residual stroma. So after the stroma is nicely removed, you go in for the graft. In keratoconus, you usually use a donor and host same graft size, or even if it's very thin cornea with a very high myopia, axial length is much more, you can use a slightly decreased corneal stromal graft also. Now the graft is cut and the endothelium is removed. The endothelium then the graft is sutured to the bed with interrupted sutures. So the intraoperative complications are perforation, rupture of the ductal membrane during trephination, during stromal dissection, and suturing. It can happen. So when a rupture occurs, then decrease the HC pressure by taking out the speculum, means tightness of the speculum. Try to decrease the DM exposure to central 5 to 6 millimeter. And if it's during trephination, suture and try at a different site. If there is a tear of more than 2 to 3 clock hours, then convert it into a PKP. So post-op complications are pseudo chamber formation, Urate-Chevalier syndrome, post-keratoplasty, atopic sclerokeratitis, and interface infections. So if in scarred corneas, you can go for a penetrating keratoplasty, which you all know very well. I'm not going into that. In pellucid marginal degeneration, the band of thinning is 1 to 2 millimeter within the inferior cornea. It can be superior also. The protrusion is just superior to the maximum thinning, the beer belly configuration. Central and protruding areas have normal thickness usually. Treatment is spectacles are not very useful in PMD. Contact lens, soft toric, RGP, and hybrid lenses can be used. Surgical approach is large diameter eccentric graft. In keratoglobus, spectacle correction can be acceptable in earlier cases. Contact lens fit difficult to achieve. Scleral lenses can be possible. You can try that. And surgical options are lamellar graft and epikeratoplastry. Thank you.
Thank you, Dr. Jairam. It's a very nice presentation. Next, I call upon Dr. Anil to cover part of Dr. Sujit's presentation, who unfortunately could not be with us. Dr. Anil, can you cover some part of it? Then I think Dr. Vinay will take it.
Yeah. I think the surgical aspect and all would be covered by. Am I audible, Prashop? Am I audible?
Little louder, sir. Little louder. You're audible. Just the volume is little low.
I think, is it okay now?
Yeah, it is okay. It's better. Just a small note, we are running a little behind time. We appreciate if all the speakers keep to their.
Yeah, Sujit unfortunately could not join due to some personal reason. So I'll be just covering for just 5 minutes broadly about limbal stem cell deficiency and transplantation. So as you know, there is a corneoscleral limbus which is seen, which is actually a very, very well-respected demarcation line. When you have limbal stem cell deficiency, that line would be lost. Another important thing is that the conjunctiva, which is usually kept at bay at the limbus, would come right into the center of the cornea, which is called conjunctivalization. Along with that, the blood vessels also will come, which is vascularization. And because there is no enough support for the epithelium quite often breaks down, and that will give rise to foreign body sensation and recurrent epithelial defects. So limbal stem cell deficiency is characterized by conjunctivalization of the cornea. There will be fibrotic changes also, which is happening along with it. Then there will be recurrent epithelial breakdown. Then there will be vascularization also happening. So on the right-hand side, what you see is a total limbal stem cell deficiency, while on the left-hand side, what you see is a partial limbal stem cell deficiency. So limbal stem cells reside in the limbal area, which is well protected. It is covered, it is within the palisades of bone, and it's quite often covered by melanocytes. Melanocytes are there to protect these very sensitive cells. So this limbal stem cells will progress to form transient amplifying cells, which can be early and late transient amplifying cells, then post-mitotic cell. And once it goes along that lineage, then it cannot come back. If it's a transient amplifying cell, if you can put again in some culture media, you can grow it in some other lineage. But once it becomes a terminally differentiated cell, it is not possible at all. So these stem cells are a small quiescent population of cells. It's a small subpopulation in most of the areas, most of the tissues in the body. In the corneal limbus, it's slightly more substantial. The important thing is that it's capable of asymmetric division. The parent cell will retain its property, and the one lineage will go on. And that is the property that is called asymmetric division. It's also capable of indefinite proliferation. So as long as the patient or the person is alive, the limbal stem cells would be alive. So it's not a finite time lifespan that the cell has got. And other important thing is, whenever there is a lot of replication happening, there are a lot of errors that can happen. It is these limbal stem cells have a very slow cell cycle, and they are capable of error-free replication, which are characteristic of all the stem cells and also of limbal stem cells. So if you classify limbal stem cell deficiency, it can be primary and secondary. Primary is often associated with conditions like aniridia, in which the population of stem cells are less, and certain conditions like multiple endocrine deficiencies, you can see the primary limbal stem cell deficiency. But what we commonly encounter in a clinical practice is the secondary limbal stem cell deficiency. One of the most common things would be chemical or thermal burns or radiation, which Dr. Vinay is going to cover. Long-term contact lens use can also give rise to some amount of limbal stem cell deficiency, but now with better material available, that is no longer seen much. Multiple limbal surgeries, along with the use of mitomycin and cryotherapy, which are basically destructive procedures, these can also lead to secondary limbal stem cell deficiency. But one of the most common two things which cause secondary limbal stem cell deficiency would be Stevens-Johnson syndrome and ocular cicatricial pemphigoid. There is another category when we have very severe vernal keratoconjunctivitis. You can get secondary limbal stem cell deficiency when it is there for long years and years, and when there is a lot of cell turnover, probably your stem cells also die off. So that's when you get limbal stem cell deficiency in vernal keratoconjunctivitis. This is an example of a patient with a partial limbal stem cell deficiency. You can see the limbus about 5 clock hours or so. The limbus is not there at all, and the conjunctiva is overgrown. Well, this is a patient with total limbal stem cell deficiency. He has only a very small island of clear cornea that is remaining. I'll just briefly tell you about this classification and then stop. When you consider ocular surface transplantation, it can be a stem cell transplantation or it can be others. I'll tell the other first. When you say about the others, it's mucous membrane graft we are talking about. So in the olden days, people used to do mucous membrane graft for recurrent pterygia. Nowadays, because we have much better techniques available, that is no longer done for pterygia at least. But mucous membrane graft is an efficacious procedure for recurrent pterygia. So along those lines, when you have a conjunctival mucosal membrane deficiency, you can utilize the oral mucosal membrane. You can either take it straight, thin it out and put it on the conjunctival surface, or you can take bits of this mucous membrane tissue, grow it outside in outside tissue culture media, and then transplant it onto the ocular surface, which is called cultivated oral mucosal epithelial transplantation, or COMET. About limbal stem cell transplantation, all the stem cells are very sensitive cells. They are very fragile, very important cells which are to be taken care of very well. So it needs a carrier in addition to a lot of other things. So in conjunctival limbal autograft, you have the conjunctiva which is acting as a carrier. So Conjunctival limbal autograft means you are taking limbus along with a bit of conjunctiva. And if it's autograft, you are taking from the other eye. So in conditions like unilateral stem cell deficiency, you utilize that. You can do an allograft of the conjunctival limbal graft also. That is, cadaveric conjunctival limbal allograft can be done. You also can do living related conjunctival limbal allograft. But nowadays, because we have other refined techniques available, we don't do that. So most of the time we use either conjunctival limbal autograft, which is from the other eye of the same patient, or you can a recent edition of that, which is called SLED, simple limbal epithelial transplant is done, which is almost similar to conjunctival limbal epithelial transplant. Only difference is that we are not taking conjunctiva. We are just taking limbal biopsy bits and putting it directly on the ocular surface. Then you have keratolimbal graft, or in which the peripheral cornea is acting as the carrier. So that also is sort of gone out of date nowadays because we have other better options available. So this cannot be done from as an autograft because it's only from a cadaver that we can take. So we have to take a keratolimbal allograft is the one that is being done. Then other thing is we can use, instead of using the conjunctiva as the carrier, we can take the limbal stem cells, culture it or expand it outside and transplant that expanded material onto the ocular surface. That is what is done in ex vivo cultured limbal transplantation. So in that, what you do is basically take small bits of limbal tissue, expand it outside using the growth factors, and usually it's the amniotic membrane that is used, and you put it back to the ocular surface. So in conjunctival limbal autograft, what you do is basically you're doing a 360-degree peritomy, and you are keeping two areas in superior and inferiorly for conjunctival limbal graft. So this is sutured in place and put an amniotic membrane on top of that. So now that the simple limbal epithelial transplant has come, which when I will be elaborating and showing the video of. So once that came, this conjunctival limbal autograft is not very much practiced, but still it can actually be done. It is quite a very good procedure. So the problem with conjunctival limbal allograft, if you take it from a related person or from a cadaver, it is that it is the histocompatibility has to be checked into. So if you don't do that, even if you do that, you have to keep the patient on lifelong immunosuppression, or else there will be progressive stem cell failure. Even if you give even if you give immunosuppression, what you have seen as an experience that there is a progressive stem cell failure over a period of 2 years. So I think that is in essence about it. Now I'll hand over the mic to Vinay, who will be talking on basically the chemical burns and its management. Over to Vinay.
Thanks, Anil. I hope I'm audible.
Yes, sir.
Yeah, my screen. Good. So we'll be dealing a little bit about the chemical injuries today of the eye. So this is an interesting case which have actually baffled me over the years, and it has been made a lot more clearer now with a lot of new understanding of the disease. So this 44-year-old male presented to me a few years back with a history of industrial injury, pipe containing sulfuric acid and other things burst and fell on his eye. And this was a presentation picture when he came to me. So what are the factors to assess when a patient comes to you like this in your emergency or OPD? So primary or the emergency management is very important in these cases. And like any other emergency case, the first thing that you assess is the ABC. The systemic status, airway, breathing, cardiac status, everything. Then MLC, very important, something which you forget when in emergency, but then you should always be on the lookout for these things. Rule out an open globe injury in such cases because this is one of the conditions where you start treating even before you take a detailed history. Okay, check the pH. Will give you an idea of what was the agent that is has caused the injury, start your irrigation. Irrigation, irrigation, irrigation. This is the first thing that you do in the emergency. After you have done a reasonable amount of irrigation, recheck the pH. And how do you recheck the pH? Stop the irrigation, wait for 5 to 10 minutes, and then check the pH. There is no point in irrigating and then immediately checking the pH, because whatever is in the conjunctival cul-de-sac will be diluted and you will not get the true pH. And it is during this period that you go into a detailed history. So history is important in assessing or giving you an idea how severe the injury can be, because the severity depends upon what agent has caused the injury. Try to get the name of the agent. What was the duration of the contact? Was there any, initial emergency treatment given at the site of injury? The degree of penetration is important, and it depends upon the agent causing it and the surface area of contact. So the nature of the, agent causing, like if it is fluid, the area will be large. If it is a solid substance, the area of contact will be small. Those things indirectly give you an idea about how severe the injury might be. Then the etiology is important, because alkali causes the most severe injury compared to acid because of the various reasons mentioned here. Okay, there is saponification, there is by the hydroxyl ion the cation penetrates, and how far it penetrates, it can penetrate even up to the optic nerve. So the injury can be anywhere from the surface epithelium to the optic nerve. Acid, on the other hand, doesn't penetrate much because of the protein degeneration, which acts as a barrier for further penetration of the agent. Now, depending upon the, as I mentioned, degree of penetration, the injury can be from surface epithelium to the nerve. Then comes the most important factor: how severe is the injury which is of this particular patient? And we know all of us have been, taught about the Roper Hall classification. But then, is this the real classification? Now, take this case for example. If you really go into it, it should be in the Roper Hall probably 1 or 2, because there is practically no corneal haze. If you see limbal ischemia, is there any limbal ischemia here? No. These pictures shows the limbal ischemia, and what you see here, the whitish is not the ischemia, it is actually the necrotic tissue. Here comes the importance of newer classification by Dua. I mean, the importance here is for the limbal involvement and not the ischemia. Limbal involvement means fluorescent staining of the limbal structures. Okay, then the conjunctival involvement, it is the bulbar conjunctiva. From the fornix to fornix, what percentage is involved? And it is graded from 1 to 6. So let us take this for example. So this looks practically okay, but then when you stain, if you see from the upper lid margin, the whole tarsus, the bulbar surface, the cornea, the inferior bulbar surface, the inferior tarsal surface to the lid margin, everything is taking up stain, showing that there is a diffuse, continuous, total epithelial damage, indicating that it is, if you go back to the Dua's classification, grade 6, which shows a very poor prognosis. But then seeing this picture, does it give that appearance? Practically no. So what all things have to be examined? As I mentioned before, the conjunctiva and other structures. Look for any necrotic tissue. It is very important, because suppose if necrotic tissue remains on the surface, it acts as a focus of inflammation and perpetuates inflammation. Always evert and look at the upper fornix, because it may have retained material, especially in children. If you cannot do it in OPD, take them in the OR, do it under GA, mandatory in children. Now, clinical course of this depends on a complex interaction between the, regenerating surface epithelium, the stromal repair and regeneration, inflammatory infiltration. So Macaulay classified into 4 grades based on, the clinical course, either immediate, acute up to a week, then a week to 3 weeks, and then more than 3 weeks. So in acute phase, grade 1 and 2 practically heals. 3 and 4, there is no reepithelialization, and you get it what is called as the first wave of cells, mainly polymorphonuclear. These are inflammatory cells which perpetuates further inflammation. Grade 2, you have the epithelium epithelialization progressing, and the limbal epithelium circumferentially progresses, closes, and then spread centrally to cover the cornea fully. If there is a defect, delay in limbal epithelialization, the conjunctiva comes in. Grade 3 and 4, no repair. You get the second wave of cells, which causes increase in collagenase activity, resulting in stromal problems. Late phase, grade 1 and 2, transient epitheliopathy, but it settles. 3, you get conjunctivalization of the cornea. 4, there is no epithelium, progressive ulceration with all other problems. So how do you manage these cases? Your goal is to promote ocular surface epithelial recovery as normal as possible. If possible, try to get a normal phenotype onto the cornea. Augment and support the corneal repair. And finally, most importantly, control inflammation, which will help in the first two processes. So medically, how do you manage this? To promote epithelialization, what we have at the moment is just tear substitutes and bandage contact lens. Probably, the hyaluronate, sodium hyaluronate drops might have an edge over others in getting this epithelialization progressing. The others, if it is available, you can use it. Then reduce the stromal ulceration or promote the stromal healing. What we have is ascorbate. Ascorbate oral, at least 2 grams 4 times should be given, and better is topical if you can get 10% sodium ascorbate. What it does is it reduces or increases the aqueous levels of ascorbate. Collagenase inhibitors in the form of what we use now is doxycycline, 100 milligram twice daily. Others are not easily available at all. And the most important factor is control inflammation. We have always been taught that steroids shouldn't be used when there is a defect, but this is one condition where you start and use steroids from the day one, whatever be the status of the epithelium. And it has to be used depending upon the extent of inflammation. Severe inflammation, you have to use stronger steroids like Pred or Dexa intensively. And then we have also been told that after 7 days, we should start the corticosteroids. That is because of the second wave of cells which stimulate or induce collagenase activity. But then, unless you have progestational steroids, don't stop corticosteroids, but at the same time, keep these patients under close follow-up to monitor for any complications. Surgical acute stage to promote reepithelialization, most common is amniotic membrane transplantation. Again, when do you use it? Probably I should say you shouldn't think twice for in amniotic membrane in the grade 4, 5, 6 of duas. First 3 probably depending on the healing patterns you can decide. I think I'll skip to the video in the interest of time, but then the idea is basically to remove the necrotic tissue and cover the entire surface. This is the same patient after 3 weeks. There is epithelialization, practically looks like normal epithelialization, but still not complete. So delayed healing. Remember, this is the first case where the Roper Hall was like 1 or 2 and Dua was 6. 3 weeks, it is healing. So is Dua's classification wrong? We'll come to that later. Other surgical techniques available as stenoplasty when there is a scleral ischemia. Then when there is a corneal melt or perforation, you can think about tissue adhesives or lamellar corneal procedures or even a large therapeutic. Now, the same case, 3 weeks, and this is the picture of 3 months. And how did this clear epithelium become like this? The answer is in what Dr. Anil said about the transient amplifying cells. Whatever persisting, transient amplifying cell continue multiplicate, to give a normal corneal phenotype till it depletes. Probably for, depends upon what the extent. One up to, if the whole TAZ is intact up to 6 months, it can replenish the corneal epithelium. So in 3 months, you have total conjunctivalization, total stem cell deficiency with significant inferior, scarring and symblyphera. So this is the cicatricial sequelae and the how shall I put it, the total stem cell deficiency. And how do you approach this case? It is stage by stage approach. The first is to get a proper lid and fornix, then the limbus, and then the cornea. This is how you address these cases. For the fornix and lid reconstruction, you may have to use conjunctiva transplant if it is a unilateral amniotic membrane, mucous membrane graft. For the limbus, stem cell transplant, and finally graft. So Stem cell transplant, how do you address it? In unilateral, you have the other eye where you have a donor. You can take a conjunctival limbal autograft, you can have a cultured, or what has been shown to be of much significance is a simple limbal epithelial transplant. If it is a bilateral disease, you have to think about donor tissue from elsewhere, either cadaveric or limbal live later. In addition to conjunctival, cultured, and SLEC, you can also have keratolimbal allografts, where you take the 360-degree limbal tissue with the peripheral cornea and sclera from the cadaveric tissues. Now, the problem with allograft is the immunosuppressive, systemic immunosuppressive, which is required. And in our setup, it is practically impossible to do that. Now, how is conjunctival limbal allograft done? I mean, limbal graft done, whether it's a autograft or allograft. You take, a conjunctiva with a limbal tissue, attached limbal tissue, and then transplant it onto the eye. And this is a short video. I'll just of how it is done. It's quite an old video because we practically don't do any conjunctival limbal autograft now. After removing the adhesions and parenus, this is a combined case. Graft is done. This is taking the graft. Either you can take through 2-3 clock hours, or you can take a continuous 6 clock hours, split it and put it. This is continuous 6 clock hours taken, 2 halves. This is the limbal tissue. This was done in the era before fibrin glue, so it is sutured and covered with amniotic membrane. And this is how the, the post-op is after. I think it's almost a year after the surgery, and this is the graft. Now, keratolimbal allografts. You take the 360-degree tissue from the cadaveric eye and transplant and cut it into multiple pieces and put it at the limbus. As I mentioned, it is done in bilateral stem cell diseases, but then the problem is systemic immunosuppressive. Just for the interest sake, I'll just show the video. This is how the dissection is done to remove the panels, and this is the limbal tissue from the cadaveric donor. This is how it is dissected. The posterior tissue is removed. Then this is combined again with a graft. This is not a preferred technique now. You don't do a graft along with limbus nowadays. And this is one way of doing it. You can put it and suture it all around. So you have created a limbus 360-degree. And this is the post-op picture. Now, after this came the cultivated limbus stem cell transplant, where you take a small limbus, sometimes around 1 to 2 clock hours of the limbal tissue alone. This is how you dissect the limbal tissue. Okay, the conjunctival part is removed and only the small limbal tissue is taken. This is then chopped into multiple pieces, put on an amniotic membrane in a petri dish and culture to get a smooth layer of cells on the amniotic membrane, and this amniotic membrane is transplanted. Again, this is the video. I mean, after the panels resection, I'll just skip through it. You put the amniotic and glue it onto the surface or suture it. So this is how conjunctival limbal epithelial transplant is done. But now what is preferred is SLEC. It's the same as a conjunctival, limbal cultured conjunctiva, but the difference is the culture media or the culture is on the eye. You take the biopsy, then put an amniotic membrane on the recipient eye, cut it into multiple pieces and glue it and cover it with amniotic. It grows on the eye. So this is a video from Dr. Sain. So again, panel dissection is as before. Now this is the amniotic membrane, which you glue it on the surface. Then this is the limbal tissue, the chopping, which is being chopped into multiple small bits. And it is spread on the surface, avoiding the central pupillary area. And then each bit you put 1 drop of the fibrin glue so that it gets stuck there. And then you put a bandage contact lens. And from each bit, the epithelium grows onto the surface to cover it. So these are some of the pictures, post-op pictures. Just the advantages, yes, it effectively restores a normal surface, improves the visual quality. It's very simple, and since you don't need lab to culture the epithelial cells, it is quite affordable and can be done anywhere in the world. You don't need a CGMP facility or any of those ultra modern things for culture. And finally, in end-stage disease where you cannot have a good biological tissue transplant, you have to think about artificial tissue or keratoprosthesis like Boston type 1 if it is a wet eye with a reasonably good fornices and blitz. Otherwise, you'll have to think about a modified osteodermokeratoprosthesis. Thank you.
Thank you, Vinay. Next would be
David.
David.
Yeah, he'll be talking on corneal storage medium.
In between, I just want to say that if any postgraduates would like to ask some questions, please use the chat box. All right?
Anyone can use, even non-postgraduate practicing ophthalmologists also, if they have a doubt, use the chat box in the YouTube link.
Okay. Good afternoon, everyone. Thank you, Anil and Dr. Gopal, for this opportunity. I'll be presenting on various corneal storage medium and various procedures of corneal transplantation. Okay. As everyone knows, the basic functions of the eye bank include donor screening, tissue harvestation, tissue evaluation, tissue processing, tissue storage, and distribution. So, tissue storage is one of the major functions of an eye bank. As you know, the harvestation procedures include enucleation and in situ corneoscleral disc excision. When you do enucleation, the whole globe is being excised. So it cannot be put in any of the medium. So a moist chamber is used for preservation of the whole globe. When you do a in situ corneoscleral disc excision, the tissue is directly transported to the different media. So, the advantage of being transported to a different medium is that it facilitates evaluation of the tissue and retainment of the viability of the tissue. So the advantages of corneal storage media include maintenance of epithelial and endothelial viability, to maintain a clear and compact stroma, to transport the tissue, and to plan the surgery electively. Three main approaches have been described, which include hypothermia, organ culture, and long-term preservation media. So based on the duration of storage, the media might be divided into short-term media, as in moist chamber, intermediate storage media, which include MK media, K-sol media, Dexol media, Optisol media, and Cornisol media, and long-term, where tissue can be stored up to 35 days, as in organ culture media, and very long-term media include cryopreservation. Here you can see the contents of each media. The short-term media, as in moist chamber, the tissue can be stored up to 48 hours. But the disadvantage is that there would be accumulation of toxic substances, which can damage the endothelium and other structures of the donor cornea. MK medium can be used for storage of tissue up to 48 to 72 hours. And other media which we commonly use is an Optisol or Cornisol medium, where tissue can be stored up to 14 days. In organ culture media, the tissue can be stored in 34 degrees Celsius and can be stored up to 35 days. One thing you should note about Optisol and MK media is that it contains an indicator, that's a phenol red indicator, which gives an indication regarding the state of the tissue which is inside. If there is a contamination, the color of the media would be changed. This would indicate that the tissue might not be viable. And coming to long-term preservation media, like gamma radiation, cryopreservation, and glycerin. In long-term preservation media, the viable cells will be destroyed, as in the epithelial cells, endothelium will be damaged. So this tissue might not be useful for optical purposes. It's mainly used for therapeutic and tectonic purposes. Methods include gamma radiation, cryopreservation, and glycerin. And once the tissue is stored properly, it might be distributed to different surgeons, depending upon their requirement and depending upon the emergency of the procedure. Coming to corneal transplantation, in this presentation, I'll try to detail regarding different types of corneal transplantation procedures which we do. based on the amount of tissue or part of the tissue which is being transplanted. It might be divided into a penetrating keratoplasty, where the full thickness of the cornea is transplanted, and in lamellar keratoplasty, where only a part of the tissue is being transplanted. When the anterior surface up to the Descemet's membrane or the Duas layer is being transplanted, it is called anterior lamellar keratoplasty. When the posterior lamellae is being transplanted, it is called the posterior lamellar keratoplasty. Coming to penetrating keratoplasty, it involves the surgical removal of the diseased cornea and replacement with the full thickness donor corneal tissue. Based on indications, it might be divided into optical, tectonic, therapeutic, and cosmetic. Optical keratoplasty. The main purpose of optical keratoplasty is to improve the visual acuity. It is one of the most common indications for penetrating keratoplasty. It is mainly done in corneal pathologies which cause reduced in vision. The common indications include aphakic and pseudophakic bullous keratopathy, keratoconus, trauma, scars following infective keratitis, corneal degenerations, and dystrophy. Coming to tectonic keratoplasty, the purpose of tectonic keratoplasty is to regain the anatomical integrity. It is mainly done in cases of perforation and corneal fistula or post-traumatic corneal loss of corneal tissue. Here you can see that there was a perforation which was sealed with a small patch graft. This is another case of PUK which was perforated in the periphery. Here a crescentic tectonic patch graft was performed to restore the anatomical integrity. Coming to therapeutic keratoplasty, when patient has a microbial keratitis, as Dr. Anita has described, and when it is not responding to the medical treatment, and when it is threatening the limbus, a therapeutic keratoplasty may be performed. It is to eliminate the infectious load and to limit the spread of infection. Here you can see a case in which a therapeutic keratoplasty was performed. Coming to the last, the cosmetic keratoplasty, it's one of the rarest indications. It is intended to restore the normal appearance of the eye in an eye which has no visual potential. And depending upon the prognosis it might be graded into excellent, as in cases where there is no vascularization at all, as in keratoconus, traumatic glaucoma, lattice or granular corneal dystrophy. Good prognosis when there is small vascularized area, and in case of bullous keratopathy and Fuchs dystrophy. Grade 3 has a fair prognosis when it is a failed graft from grade 2 graft, when there is a moderate vascularized cornea, when there is a stromal keratitis from viral keratitis, congenital hereditary endothelial dystrophy. And guarded visual prognosis include mild dry eye, active fungal keratitis, corneal staphyloma, corneal blood staining, and all. And the most worst prognosis is for cases with ocular surface problems, as in severe dry eye, ocular cicatricial pemphigoid, Stevens-Jones syndrome, and in chemical burns. Coming to the surgical steps. The surgical steps include trephination of the donor and the host cornea. The donor cornea is trephined such a way that the donor tissue which is obtained is 0.5 millimeter larger than the recipient corneal trephination. This is to maintain the depth of anterior chamber and to regain the normal anatomical contour of the cornea. Here you can see that a partial trephination has been performed, but the anterior chamber has not been entered. Anterior chamber might be entered with a stab incision, and aqueous might be replaced with visco. This is followed by trephination of the dissection of the corneal tissue in 360 degree with the help of a corneal scissors. This is after removal of the corneal tissue in 360 degree, exposing the lens. This is followed by application of the sutures. The initial 4 sutures are called the cardinal sutures. These 4 sutures help to secure the graft onto the recipient corneal bed. Here you can see that initial 4 cardinal sutures are placed. This is followed by the placement of the rest of the 4 sutures. The sutures always maintain a radial orientation. With the placement of the first initial sutures, anterior chamber can be easily formed with saline also. This is followed by placement of the rest of the 8 sutures to complete the 16 sutures. and a watertight anterior chamber is formed. Here you can see that the sutures are not buried. At the end of the surgery, the sutures should be buried. This is to limit the amount of vascularization and to reduce irritation to the patient. Based on the suturing technique, different techniques have been described. This include single interrupted sutures, combined running and interrupted sutures, single continuous running sutures, and double continuous running sutures. The complications include intraoperative complications can include scleral perforation, donor corneal damage, damage to the Descemet's membrane, Descemet's stripping, Descemet's detachment, retained Descemet's membrane from the recipient cornea causing a double anterior chamber, damage to the iris and lens, vitreous loss, and expulsive hemorrhage. Postoperative complications include wound leak, flat anterior chamber, iris prolapse, epithelial complications like epithelial defects, filamentary keratitis, suture-related complications like breakage, protruding knot, and glaucoma and pupillary block are the described complications. Late complications like graft rejection, graft failure, infections are also common. Postoperative regime consists of treatment regime consists of topical antibiotics, topical steroids, lubricants, and cycloplegic, and a suture removal at approximately 1 year postoperative period. Coming to next, I will proceed to the lamellar keratoplasty. The anterior lamellar keratoplasty may be divided into a Bowman's membrane transplant, superficial anterior lamellar keratoplasty, and a deep lamellar keratoplasty. A Bowman's membrane transplant is performed in case of keratoconus, where a femtosecond pocket is made on the recipient cornea, and Bowman's membrane from the donor cornea is transplanted. This is said to regain the anatomical integrity as in cases of keratoconus and to halt the progression of keratoconus. In superficial scars, which cannot be removed by phototherapeutic keratectomy, a superficial anterior lamellar keratoplasty may be performed. This might be performed with the help of a femtosecond laser or with the help of a microkeratome. Deep anterior lamellar keratoplasty has been described in detail by Dr. Jairam. So I'll skip the slides on deep anterior lamellar keratoplasty. I'll just describe regarding the different types of bubble in inverse big bubble technique. So as Dr. Jairam has described, an air bubble may be used to separate the posterior stroma from the Descemet's membrane. So 3 types of bubble have been described in inverse big bubble technique. The type 1 bubble is formed when the air separates the Duas layer from the deeper stroma, and type 2 bubble is formed when the Descemet's membrane is separated from the posterior surface of the Duas layer. And a mixed bubble is a combination of these 2 bubbles. Rest of the details have been covered by Dr. Jairam. So we'll proceed to endothelial keratoplasty. Endothelial keratoplasty or posterior lamellar keratoplasty has been divided into multiple techniques. DSEC stands for Descemet stripping endothelial keratoplasty, where a manual separation of the lamellar separation of the donor tissue is obtained. Whereas in Descemet stripping automated endothelial keratoplasty, a microkeratome is used to separate the posterior lamellae of the donor cornea from the superficial lamellae. And DMEC, where the Descemet's membrane alone is transplanted. And pre-Descemet endothelial keratoplasty, where the lamellae of separation is just anterior to the pre-Descemet's plane. Coming to the DSEC, the main indications of DSEC include endothelial dystrophies, bullous keratopathy, endothelial failure due to previous surgery, iridocorneal endothelial syndrome, and in failed PK. Here, one of the indications is that the stromal clarity should be perfect. If there is a good, clear stroma, then only the endothelium can function properly and help in optical function of the cornea. It is also contraindicated in keratoconus and hypotony, where an air bubble which fills the anterior chamber to maintain the graft position might not be possible. So coming to the steps, the donor tissue is in DSEC. The donor tissue is mounted on an anterior chamber, and with the help of straight and curved dissectors, a lamellar separation in the proper plane is obtained. This is followed by trephination of the donor cornea to the required site to obtain the correct size of the button. And coming to the recipient cornea, the Descemet's membrane is stripped with the help of a reverse Sinski. A complete removal of the Descemet's membrane is required for proper attachment of the donor button. Different techniques of donor tissue insertion or donor button insertion have been described. Various types of injectors like Mechalso injector, Bucine glide, Tan's endoglide have been described. This is a Mechalso injector and this is a Bucine glide which has been used. A 26 gauge needle may also be used for insertion of the donor tissue. And the technique is using a taco technique where the donor tissue may be folded on itself and is inserted into the anterior chamber with the help of a forceps. Once the donor tissue is inserted in the anterior chamber, an air bubble is used to secure donor tissue into its position. Once the donor tissue is secured into its position, a tight airfill of the anterior chamber is obtained to facilitate adhesion of the donor tissue. A peripheral iridectomy may be performed to prevent angle block or pupillary block. This is a postoperative picture following a T6 surgery. The complications include, intraop complications include wrong graft orientation of the graft, where the stromal site may be facing down. Graft expulsion might occur. Direct trauma to the endothelium might occur. Problems with air management may be faced, as in cases with the previous glaucoma filtration surgery or glaucoma drainage device surgery, iris defects in anterior chamber IOL or SAK for vitrectomy phase patient. Postoperative period, there might be a graft dislocation, primary or secondary graft failure, graft rejection, pupillary block, Tourette-Chevalier syndrome, or IOL opacification because of the air. Here, this picture shows a descended graft. Here, on a slit lamp examination, you can see a cleft between the donor corneal button and the recipient cornea. An isosceles picture showing a cleft between the recipient button and the donor corneal tissue. Coming to DMEC. DMEC stands for Descemet's membrane endothelial keratoplasty. Here, the Descemet's membrane alone is transplanted onto the recipient cornea. The Descemet's membrane from the donor tissue is stripped in a proper manner and is loaded into a cannula. A Goudas cannula is usually used to transplant the Descemet's membrane. Here, inside the cannula, the Descemet's membrane forms a scroll, and this scroll is generally inserted into the anterior chamber. When the scroll has been passed into the anterior chamber, it is unfolded with the help of gentle tapping movements and with the help of gentle injections of air. Once the tissue has been unfolded in the proper orientation, air is injected underneath the Descemet's membrane to secure the Descemet's membrane into its position. A peripheral iridectomy should always be performed to prevent pupillary block. This is followed by tight airfill of the anterior chamber to retain the Descemet's membrane in its position. The advantages of DMEC include it facilitates a faster visual recovery, there is a low rejection rate, and there is a high quality of vision. The common post-intraoperative challenges include difficulty in graft preparation, difficult handling and unfolding of the graft and ensuring the proper orientation, iatrogenic graft failure, and high rates of graft detachment. Thank you.
Thank you, Dr. David, for that wonderful talk. So we have come to the penultimate, the last talk of the day, the last talk, but one of the most important talks. It is going to be on corneal graft rejection and failure by Dr. Anil Radhakrishnan, who is a senior consultant at Amrita Institute. Before I go to the talk, I want to announce the finalists for the quiz. I'm happy to announce that our quiz was sort of a national quiz, and there are teams from all parts of India who participated. And the top 4 finalists, not necessarily in the order of their ranking, are Dr. Maria Doctor from L.V. Prasad Institute, Hyderabad, Dr. Nadna Bashir from Girdhara Institute, Kochi, Dr. S. Chandra Devi from RP Center, Leeds, and Dr. Adiraj Devaraj from Jipner, Pondicherry. Congratulations to all the finalists. After this talk, we'll be having the final round for the quiz. The participants are requested to get ready with their laptops, etc. Dr. Anil, over to you.
Yeah. Am I audible, Prashov?
Yes, sir. Loud and clear.
Okay, fine. So nice to hear that it's a national quiz. So the last talk of the day would be about graft failure and rejection. As you know, a clear graft with radial sutures, it's a delight to the operating surgeon. But when it fails, it's really heartbreaking quite often. So graft failure is defined as the failure of the corneal graft to achieve the standard aim of performing the procedure. And often it is interpreted as basically irreversible loss of vision with a particular cornea or the graft. So the graft failure can be primary or it can be secondary. Primary graft failure means the cornea, to start with, it has never regained its transparency when from the day one it is opaque and the patient does not have any vision. That when you open the patch the next eye, you see that the patient has got a gross corneal edema with a lot of DM folds, and there is no improvement that is seen in the immediate postoperative period. You call it a primary graft failure. This usually is the result of a poor donor tissue. So it can be the delay in the death enucleation time. It can be a poor endothelial count to start with. Whether it can be an elderly patient who had already had a cataract surgery and to start with the endothelial count was bad. This is all possible, but surgical trauma also adds significantly to that. So it's well known that about 25 to 30% of endothelial cells are lost during surgery. And if you do this DMEC and all that, DMEC and DSEC, the amount of endothelial loss is more. But again, different techniques in that also, some techniques have got better results compared to the other techniques. So if you have a very messy surgeon, the amount of primary graft failures that you have would be very high. Regarding the secondary graft failure, it occurs in a graft that has been functioning pretty well in the immediate postoperative period. And it has been, the patient and the doctor has been happy. And after a period of time only, the graft fails. So the most common cause of that would be graft rejection, and that too endothelial graft rejection. Some people are more prone to have it, like people who have anterior chamber, old style anterior chamber intraocular lenses within their anterior segment. So quite often we see that during surgery, it is very bound down to the iris, and it is quite traumatic if you try to remove it. So in such scenarios, we tend to keep the lens. So in people in whom the ACIOLs are there, the chances of rejection, the chances of failure is slightly more. One of the other common things would be the progressive endothelial decompensation, which I'll be coming into later. Other important factors are uncontrolled intraocular pressure, inflammation, and as well as infection. So I'm just re-emphasizing the point because a lot of postgraduates have seen that they quite often interchangeably use the terms rejection and graft failure, which is not correct. Rejection is an immune phenomenon. It can be epithelial, subepithelial, stroma, or endothelial, and it is reversible usually. And if it is treated early, it is 100% reversible. But failure is not like that. It is a consequence of rejection. So it is a sequelae of rejection. So there can be multiple causes for that. One of the important causes would be rejection. Other than that, progressive endothelial loss. That means the rate of endothelial loss would be more in a graft compared to a virgin cornea. So over a period of time, say after 10, maybe 15 years, the endothelial count would be very low and you have to replace the graft because the endothelial count in the graft is not able to keep the graft compact or clear. The other important cause in our scenario at least would be infection. So that is quite common, and that's why we all tend to remove sutures pretty early in our scenario. The other surface issues also can cause graft failure, whether it is a persistent epithelial defect, whether it's limbal stem cell deficiency, and a lot of other things. then there can be a recurrence of the disease, then there can be glaucoma. So everything, each and everything that causes the graft not to work can result in graft failure. But rejection, in contrast, is an immune-driven procedure, immune-driven phenomenon, and that too, that is working against only the graft tissue. So an example, this is a patient who had a fungal keratitis, which was almost reaching the limbus. And I think I did the transplant a few days later when there was a limbal involvement. So I had to take a large eccentric graft. So this initially, in the initial period, the patient had a clear graft, but he developed a graft rejection. So the same patient was treated for rejection. There was some improvement, but the improvement was not good enough to keep to reverse the edema in the graft or to restore the corneal clarity. So this patient who had, in the first day of presentation, you call it a graft rejection. You treat it for 3 months and you see that there is no improvement, then you call it a graft failure. So that is the difference between graft rejection and graft failure. So if you look at the incidence of rejection, up to 30% of keratoplasties, penetrating keratoplasties, at least have one episode of rejection. And on an average, 5 to 7% lead to graft failure, which tells you that most of them definitely survive. And if you look at the immunopathogenesis of the allograft rejection, I think I won't go into much details, and it's slightly difficult for us to understand also because we are not really studied immunology well. So I think it's very important to realize that when you put in a graft in a cornea, when you put in a graft, you have this antigen presenting cells which are there in the peripheral cornea, which can recognize the antigens either through the direct pathway or through the indirect pathway. It can actually stimulate this T cell population to increase. So this can be either CD4 or CD8 cells. CD8 cells, as you know, are cytotoxic cells. In the efferent arm of the allograft rejection, you have the CD8 cells which are active, which are actually causing cytotoxic destruction of the endothelial cells. So when the efferent arm is active, you can see that the endothelial cells are actually killed. So when if it is a graft in whom the arcade is lost, or if there's a heavily vascularized graft with a lot of lymphatics, a lot of cytokines also come into play, and the process of allograft rejection is much more complicated, much more similar to that of a solid organ transplantation. So cornea is actually an immune privileged site. It does not have any lymphatics or blood vessels. The lymphatics actually carry these antigen presenting cells, and basically they are very important in the pathogenesis of rejection. Then you have this blood-eye barrier. Then there is an expression of Fas ligand on the corneal cells, which actually causes the cornea to be immune privileged. Basically, Fas ligand expression, basically it reduces the activity of polymorphonuclear leukocytes. So there are other things also, like there is a lower expression of class 1 and class 2 MHC cells. Then there is even the population of antigen presenting cells in the cornea is very less. Actually, it's only present in the peripheral cornea. Very rarely we see in the central cornea. So all these together actually give a immune privilege to the cornea. And there is something called anterior chamber associated immune deviation. I think it suffices to understand that it's a down regulation of systemic delayed type of hypersensitivity. And basically, it helps also in reducing the chances of rejection. There are a lot of factors also within the aqueous which actually works in favor of preventing a rejection happening. So immune privilege of cornea has basically 3 major mechanisms. One would be the anatomical and the molecular barriers that is present in the eye. Then you have the arcade or anterior chamber associated immune deviation. Then other immunosuppressive intraocular microenvironment. All these, a lot of cytokines are downregulated within the anterior chamber. So what are the risk factors for rejection? There are multiple risk factors for rejection. One of the most important things would be the presence of corneal vascularization more than one quadrant. The other risk factors would be a pediatric age group. All pediatric grafts are actually high risk grafts. In fact, any graft which is done in a person less than 40 years carries more risk. The presence of peripheral anterior SNK, presence of a previous graft, and regraft more than 2, the risk of rejection would be much, much more higher. And when you have active ocular inflammation like HSP keratitis, you should not do a graft. There are other intra or postoperative factors also. When you do vitrectomy and keratoplasty together, there is slightly higher chance. There is some people say that if you have bleeding intraoperatively, that also augments the chances of rejection. If you have a large or an eccentric graft, then also because you are more closer to the limbus, you can have more amount of rejection. Then, as I said before, if the eye is inflamed, like in a therapeutic keratoplasty, the chance of rejection would be definitely more. Then if you are not following up the patient well, if the patient ends up with a loose suture and an epithelial defect and some debris settling on the suture knots, that will cause some irritations, provoke some inflammation, disturbs the immune mechanisms, and can be a precipitating factor for rejection. And the presence of peripheral anterior SNK also is definitely, because the iris is a very vascular tissue which has got a lot of, which is close to the immune system. And if it comes close to your graft, then the chance of rejection is much more accentuated. So I'll just show a few demonstrative examples. This is the one I showed before. If you have a large graft, you are basically closer to the limbus, and then you are more closer to the immune system. Any graft actually which is more than 8.5 millimeter is a risk factor. So once you cross 8.5, the chance of rejection significantly increases. Up to 7, up to 8, it is quite okay. Then, as I said, large grafts, for example, in a patient who has who was planning a therapeutic keratoplasty like this, you have no other option but to do a large graft. Because it's limbus to limbus infiltrate, you have to remove the whole of infected material. Then only you can have a possible good result. So sometimes there are multiple risk factors in play. You have this is a patient who has undergone a therapeutic keratoplasty, a large graft has already been done. You can see a small amount of reddish color or a pinkish color in the central part of the graft, which suggests that there are stromal blood vessels there. There is a history of penetrating keratoplasty, and there is peripheral anterior SNK in the periphery also. There are multiple risk factors in such a patient. So this patient has to be on a more controlled follow-up. It's better to give this patient systemic immunosuppression also. I think this CCTS or collaborative corneal transplant studies have shown that the ABO incompatibility slightly increases the chances of graft survival. I'll go to graft rejection now. There are multiple types of graft rejection. Most prominent one would be the endothelial rejection. Graft rejection by definition is an immunological response of the host to the donor corneal tissue without regard to the effect of the response on graft survival. So if you treat the rejection very early, you can easily reverse it. That is the essence of it. So if you want to call it a rejection, you have to make sure that the graft has been clear for some time. If the patient had a corneal edema right from the day one, you don't call it a graft rejection. It's in a graft which is normal, functioning, clear. In that, suddenly there is a decrease in vision and there is corneal edema. Then you call it rejection. Then you assume that it is because of an immunological process. And often, if it's an endothelial rejection, it's associated with graft edema and other anterior segment inflammatory signs. Epithelial rejection is something pretty uncommon. This is a file photograph from Columbia University. We don't see very much in our practice because quite often it is asymptomatic and the patient do not come to you. So you have a raised epithelial line. This actually can travel from the periphery to the central part of the cornea. The important thing is that it can actually be a precursor for the endothelial rejection. And whenever you see this epithelial rejection, you treat it with topical steroids, only with topical steroids, nothing else. Topical steroids and maybe lubricant drops or artificial tears, but nothing else. There is no need to give systemic therapy. There is another form of rejection which is called anterior stromal infiltrates, which is something very similar to that of adenoviral keratitis. So how do you differentiate between adenoviral and anterior stromal infiltrates? which is because of rejection. So in a rejection, it will be present only in the grafted cornea. In adenovirus infection, it will be present in both graft as well as host cornea. Rarely you can get a stromal rejection also. This also actually settles down pretty fast. You just need to increase the steroids. The general treatment is to give steroids 6 times a day. The prescription would be prednisolone acetate 1% or dexamethasone 0.1% 6 times a day. Stromal rejection typically occurs in a deep anterior lamellar keratoplasty. When you see stromal edema, you take it as endothelial rejection in a penetrating keratoplasty. It can possibly be stromal rejection also, but endothelial rejection, as you know, is much more dangerous, so we have to treat it as endothelial rejection for the best benefit of the patient. So endothelial rejection is characterized by, there is a rejection line that you see quite often. Then there will be a lot of stromal edema. Then there will be a sudden increase in the anterior chamber flare and cells with keratic precipitates on the endothelium. There will be an increase in the corneal thickness or corneal edema in a previously clear and compact graft. And usually it starts at the graft-host junction. This is a typical example. Actually, you can see if you look at the graft, the upper half of the cornea is clear. The lower half has got stromal edema. It is almost double the size of the upper part. It has got multiple Descemet's membrane folds. And usually the graft rejection happens in the area where a lot of blood vessels are there. If you see, this is a patient who has already undergone a therapeutic keratoplasty. In this, you can see that this graft is more towards the periphery in this, and there are a lot of blood vessels coming in that area. So this is basically the usual picture that you see in an acute rejection. Also, when you see rejection, you should, as I told before, it is basically caused by cytotoxic T cells. So cytotoxic T cells are basically marching in. It is you can imagine this as the Indo-Pak or Indo-China border, and these are crossing the border and reaching the endothelium and killing the cytotoxic. The cytotoxic T cells are killing the endothelial cells. If you act early, a lot of it is reversible. But if it is damaged forever. Then the other endothelial cells have to compensate for the lost cells. This is the characteristic thing that is described for endothelial graft rejection, which is called the Cordados line. Cordados line again is seen near the area of graft where there is a vascularization of the graft host junction. So you see a sectoral corneal edema or a differential corneal edema. One part would be more edematous. And the Cordados line actually segregates the area of clear cornea and the edematous cornea. So you can think of this Cordados line as actually the frontline barriers. So the cytotoxic T cells are coming from the host area into this, and you can assume that up to that area, the endothelial cells are damaged. So as you know, corneal graft rejection is one of the commonest causes of graft failure. The rejection rates are around 12 to 13% in low-risk grafts, while in high-risk grafts, it goes very high, sometimes 30, 60%, even 75%. So how do you treat rejection? What I meant is an acute allograft rejection, which is called endothelial rejection. So the standard, the drug of choice would be topical steroids. So topical steroid is the first line treatment. You have to give 1% prednisolone acetate 1 hourly till the patient goes to bed. So as you know, these cytotoxic cells are coming basically from the lymph nodes. So you want to basically give a knock to the cells which are coming from there also. So you have to give some systemic agent. So for the quick action, we give IV methylprednisolone. 500 milligram is the dose given, 500 milligram in 3 doses, like 1, 2, and 3 consecutive days, you give 500 milligram. A lot of US people use only 125 milligram instead of using 500 milligram. And this is followed by oral prednisolone, 1 milligram per kilogram, which is tapered every week. So usually the treatment is for about 6 weeks. And by the time the graft should have recovered. So after the first 5 days or 7 days, you can taper the dose of the topical as well as systemic steroids, and looking also at the clinical findings. So these are the, we talked about the predisposing factors, the risk factors. There are certain precipitating factors also for rejection. Like if you do a suture removal, actually you have to increase the dose of steroids, because this actually can be a precipitating factor for rejection. If you do again a capsulotomy, you have to increase the dose of steroids. If the patient receives a blood transfusion, again, it's better to give an augmented dose of topical steroids. And if the patient obviously undergoes an ocular surgery, we have to give steroids. So this basically disturbs the fine tune between the graft and the host. And you want to tone down the immune response by giving topical steroids. So we were basically telling about graft endothelial rejection till this point of time. The second important category is the endothelial decompensation, progressive endothelial decompensation, which happens in a penetrating keratoplasty. As you know, a normal endothelial loss is about 0.6% every year. But in a post-penetrating keratoplasty scenario, the cell density is significantly reduced in the first 5 years. You can see that it's definitely less than 50% in the first 5 years. Even if you follow up these patients between the 5 and 10 years, you can see that the rate of endothelial loss is almost 7 times the normal. It is about 4.2%. So taking all into consideration, an average graft will last for about anywhere between 10 to 15 years. So at 15th year, from the 15 years time period, you have to think of doing a regraft. So at this point of time, we have seen that endothelial keratoplasty or descemet stripping endothelial keratoplasty or DMEC is a much better procedure than doing a regraft. A lot of studies have shown that if you replace only the endothelium, that is got a much higher chance of long-term success. This is an illustrative example. This is a patient who had fungal keratitis, was treated vigorously with natamycin. There were some anterior chamber exudates, and so we gave intracameral amphotericin B also. But the patient ended up with a good scar along with a total cataract, for which 1 year later, optical keratoplasty plus cataract surgery was done. And patient had good visual acuity. He had a best corrected visual acuity of 6/9, which he maintained for a long period of time, about 8 years or so. Then in 2014, he developed a sudden decrease in vision. We saw that he had his cornea was clear at that point of time. He was seen to have a rhegmatogenous retinal detachment. So our retinal surgeon did a vitrectomy with gas injection, and the vision was restored promptly to 6/36. So already the patient's endothelial count was very low, having it's almost more than 8 years since he had undergone this transplant. So his endothelial, to start with only, endothelial count was low. So on top of that, there will be some amount of endothelial damage because of the vitrectomy, or in fact, any other ocular surgery that you do, there will be some amount of trauma to the endothelium. So before the vitrectomy, it was the specular microscopy was 1050, and 6 months later, it was seen to be 800 cells per square millimeter. Over a period of time, his graft started showing a few pigments on the endothelium, minimal edema. We gave steroids, but to no avail, because it's not rejection. It's basically progressive endothelial decompensation. Over a period of time, the graft became white and had to undergo a regraft. So this is another demonstrative example of infection which leads on to graft failure. Patient who had a therapeutic keratoplasty done had a small infiltrate on the grafted cornea, which was edematous, which went on to become graft failure. So all these graft infections, they behave slightly differently. I think whenever you have a graft infiltrate, you have to treat it more aggressively. And if it is related to the sutures, most of the time it is pneumococcal infection. So if it is a suture-related infiltrate, it is pneumococcal unless proved otherwise. So in such a scenario, you take out the suture and plate it in a blood agar. Most of the time, it will grow pneumococcus. And start treatment for that. And if you treat it early, most of the time the bacterial infections can be taken care of. Even fungal infections can be taken care of. Only thing is, if it is a fungal infection, you have to stop steroids, and then the risk of rejection will go up. This is a patient who had 2 years post-transplant. He had a graft infection. Did the scraping, found that it is Pseudomonas. We treated with all anti-Pseudomonas drugs possible. We are putting hourly drops, but it was not improving and had to resort to a larger therapeutic keratoplasty. The other causes of graft. Prashop, 1 minute. Prashop, are you there?
Yes, sir.
Yeah. You can, like, if the time we are exceeding the time, no, you can ask me to stop.
We have about 10 minutes left for the question and answers also. You can wind up.
Yeah. I think I'll wind up in 2 minutes. Yeah. So other major category is non-attachment. So this is pretty common in deep anterior lamellar keratoplasty. So like there is no apposition of the Descemet's membrane and the endothelium to the hosted stromal tissue. So it can remain separate, and obviously the graft will remain edematous. So in the post-keratoplasty requires very good follow-up, and even after a year, we require to follow up the patient every 3 months. And at every visit, you have to check the vision, intraocular pressure, that is minimum, and the disc assessment should be done at least every 6 months. And warning symptoms should be always emphasized to the patient. If the patient sees redness or drop in vision or photophobia or sensitivity to light, they have to report immediately. Quite often, this will be rejection, and if you treat rejection early enough, it can be reversed. So this is some data from L.V. Prasad, who looked at about 1,725 eyes. Based on the category, if you see the topmost line, it is of keratoconus, which had at 5 years of follow-up, more than 95% of them were retained in the graft. But if you look at the other scenarios, even in other dystrophies, the success rates were something like 60%. In pseudophakic and aphakic bullous keratopathy, it was even less than that. So its follow-up is something very, very important. I don't think I'll go into this. Yeah. So this grafted corneas also can get some complications. When you see something like this, you think of rejection versus infection, but this is usually infection, because in this particular scenario, you can see on the right-hand side near the limbus, you can see there is some exudate sitting on the endothelium. So most likely it will be a fungal keratitis. So we treated conservatively to no avail, had to do a regraft. And now this patient can undergo a optical keratoplasty or a DSEC. DSEC would be better for in this scenario. So options for a failed graft would be to repeat the graft. It's better to do a DSEC or a Descemet's membrane endothelial keratoplasty if the corneal clarity is good, or a Descemet's membrane endothelial or a DSEC. In the corneal clarity, if the stromal clarity is not good, you have to go for a repeat keratoplasty. The timing, obviously, you have to wait for the rejection and the immune process to settle down. So it is better to wait for up to 3 months to 1 year before you attempt a regraft. I think I'll wind up now. Thank you.
Thank you, Dr. Anil, for that wonderful talk. So I think we will proceed to the question and answer session. There are a few questions on the YouTube chat box. One question is, what are the Eye Bank Association guideline? EBI K is what is written. EBI I is what I think the question meant. Guidelines for retrievals in COVID times. Any of the panelists volunteer to answer? EBI guidelines for retrieval in COVID times. It's only XARP, only accident death retrievals. How is it going to be?
Vinay, I think you should unmute yourself.
Yeah.
Who's taking the question?
Anyone can take it.
So actually, the Eye Bank Association of India says that COVID testing has to be done. And actually, we have to keep the tissue in a MK medium or any other medium. And actually, the tissue is actually quarantined. And till the result come, we will keep the tissue under quarantine. You will disperse the tissue only if you see that the COVID test is negative. But Eye Bank Association of America does not believe in that. They see that they feel that if the patient do not have any symptoms or other factors suggestive of COVID, you don't have to do COVID testing. It's a moot point whether you can discuss actually whether the COVID gets transmitted through the conjunctival secretions. I think if you look at the studies, it is seen that about 1% would carry this COVID virus in the conjunctiva. I think there are multiple studies there. I think approximately 1%. And there is nothing to suggest that there will be COVID within the aqueous. So that is it.
I think the current AIOS guidelines also have touched upon this, and there's a separate section for eye banking, the AIOS guidelines. And what AIOS has recommended is that avoid home retrievals. Home calls should be avoided. And COVID testing, if possible, it's well and good, that's what they say. But it is the issue whether it should be used or not, whether it should be retrieved or not, should be that question should be answered by the medical director according to his clinical activity.
Can I make a comment?
Yes, sir.
Can I make a comment?
Yes.
The other than the tissue, I think the health of the people who go to retrieve the cornea.
Yes, I was just coming.
That is also an important point that, we have to look into, because if you look at many of the countries, for example, in UK, one person I know who's a pathologist contracted COVID while doing a postmortem for an unknown cause of death. The coroner asked them to do the postmortem, and he acquired the COVID infection due to that. So I think whenever someone goes to retrieve a cornea from a dead person, making sure that the patient did not die of COVID, I think is very important for our staff who go to retrieve the cornea. So I think that is also something that we have to consider. I don't know what the cornea specialists feel about that.
AIOS also has recommended full hazmat suit for those who are retrieving corneas. The technicians who are retrieving corneas should wear full hazmat suits, per se. And when I spoke to the doctor David to and say touch upon that, I think their cornea levels have come down.
We have started our enucleation procedures. What we do in EBAK is that we do a thorough screening regarding the history of contact exposure and COVID symptoms. Usually, we take only from our hospital so that we have a detailed description about our patient. And we always get in touch with the physician treating the patient so that we know what all are the symptoms of the patient. Is there any risk of COVID? All this history will help us to decide whether a tissue has to be taken or not. And also that COVID testing currently in our scenario, it's not possible for us to do COVID testing for all donors. So COVID testing is not done. And we always make it sure that we take tissue from our hospital only so that we have a rapport with our physician. We can contact our physician to know the history and all. And there is no donation or no harvestation from any febrile patient. That's what we do. The technicians have been trained in usage of PPE and all sterile measures, and they wear complete PPE for the harvestation procedure. And currently we are taking tissues only for emergency procedures like therapeutic keratoplasty and perforated corneal. We have not started doing any optical keratoplasty till now.
Basically, fever, respiratory symptoms, those patients are out.
I think
contact history also, and any history of any contact with any quarantine patient.
Yes, ma'am.
You were saying something.
I think Rama Bank from LVP, they have started all elective procedures. That is what I heard about 1 week before. And they have started retrievals from accident deaths only. But accident deaths also, we can't be sure.
Sure,
Correct,
we cannot.
They positive as in our.
Correct.
The current scenario is that only very few patients satisfy for a donation. Most of the patients who die in the hospital either have a fever or any history of any respiratory symptoms with this. So we hardly have got 1 or 2 corneas till now. That is the only, and all were above 70 or 75 years of age, which cannot be used for an optical purpose also.
That's the message I was getting from the different eye bank managers, that practically they are not able to collect anything. When we take all this into account, the number of corneas that we get will be less. So I think probably the elective procedures will have to postpone for at least 1 or 2 months. Keep all the corneas in, after keeping cortisol, maybe transfer to glycerol for emergency therapeutic purposes. Because that also we are having a shortage. There's another question on the YouTube link. Dr. Chanel K asks whether PK versus talc in macular dystrophy in a stage where endothelium is not involved. Which one is preferred? Dr. Jairam, can you answer?
Can you hear me?
Yes, a little bit louder. Can you speak? PK versus talc in macular dystrophy where endothelium is not involved, which is preferred?
And endothelium, if endothelium is not involved, you can go for talc only. But there are reports that it can recur in the graft also. If it happens, you can again change the button and do it again, maybe after a few years. Endothelium is not involved, you can definitely do talc itself.
Dr. Vinay, would you like to add anything?
Talc is always preferred over PK in whatever condition it is of endothelium. Unless there is frank edema, the presence of Gatte alone is not a contraindication for talc in macula. The only problem is that the type 1 bubble, which is what we commonly get, will leave a 10 to 15 micron of stroma behind. Okay, the early recurrence in that is possible of haze because of the macular dystrophy progression, which can affect the quality of vision and reduce the vision. So otherwise, yes, talc is always the first choice.
Yeah, Reddy sir also wants to add anything regarding the earlier point. Ma'am, you are saying something.
What about in early decades? It is early decade of life in macular dystrophy. It is safer. Talc is safer, but in later decades, talc versus PK is a concern because sometimes you will get deficits till the endo. So if you are doing, if you are completely bearing the Descemet's membrane, then it is fine with talc. But if you are doing leaving some stroma, then it might hamper vision in later decades in a patient with macular dystrophy.
May I ask a doubt for the PG Scott? May I ask a doubt? Yeah. So we have a case of penetrating keratoplasty in which the host cornea is also involved with a dystrophy. So now we have, this is a post-penetrating keratoplasty case, and the host cornea is involved. So what are our differential diagnoses? This may be an exam case. I'm just hypothetically asking.
I actually get the question. Can you be a little louder, sir?
You have to unmute, doctor.
Gopal sir, can you come closer to the mic? It's not
Yeah. So can you hear now?
Yeah, it's better.
Yeah. This is a case of penetrating keratoplasty which is kept in the exam, and the graft is very clear. But around the graft, in the host cornea, there are some dystrophic changes. or some opacities right in the periphery till the limbus. So what are our differential diagnoses in such a case?
Can I just clarify the question? The penetrating keratoplasty was done. The graft is clear, but there are problems with the host area. What should be done? That is the question.
No, it's not that what should be done. I am asking the differential diagnosis of the original diagnosis. For which a penetrating keratoplasty was done.
All of them are muted, I think.
It can be residual stromal opacities. What I got from the question is, graft has been done. The central graft is clear, but the peripheral pathology will remain. No? Central 8 millimeter graft only is clear, and the peripheral, whatever scarring or deposits or dystrophy, the peripheral pathology of the stroma is remaining. So depending upon the morphology, you can tell whether the patient was having a dystrophy or a scarring or any other disease.
So how will we make that differentiation, and what would be our differential diagnosis? How will we come to a pinpoint diagnosis?
If the deposits are like in a macular dystrophy, like reaching up to the periphery, all the layers of the stroma there are deposits, then it can be a macular dystrophy. If it is a full thickness scar, then it can be a corneal degeneration following multiple infective keratitis causing a full thickness scar, and following which a PK was done.
Okay. So, Prashop, can we move ahead?
Yeah. I think we should go with the quiz.
I think the panelists, the cornea panelists should remain, if possible, because you are the judges in case of any sort of third umpire situation.
First of all, I'd like to thank all the panelists for their wonderful talks. Despite their busy schedules, they are less busy now, I guess. But they have joined in for a longish session. I think the PGs would have enjoyed it thoroughly. And a lot of thanks to Dr. Sai Kumar and Dr. Gopal for making this possible. We are having, first time I think COC is holding such a long webinar. This must be the longest webinar we have held so far. So moving on to the quiz. So we have the 4 finalists with us. As I said before, this was a national quiz. We didn't intend it to be national, but it spread organically and became national. And among the finalists, we have students from some of the most eminent institutes, one of the best institutes in Kerala. So I think I'll go to the presentation of the quiz right away.
Can you please tell us who are the finalists?
Yes, sir. Yeah, that's coming up. So this is the Kera quiz. This is a Super Sunday on cornea, and COCHIN Ophthalmic Club has conducts a quiz at the end of all these Super Sundays. So it's the cornea this time, and this is our team. It's myself, the quiz master, and Dr. Manju Anush, who's helping me with the scoring and a lot of other things. These are the finalists. If the finalists could please introduce themselves. The first participant, this is not necessarily in order of marks, it's a jumbled up order. The first participant will be Dr. Maria Doctor from LV Prasad Eye Institute, Hyderabad. Please introduce yourself.
Hello all. I'm Dr. Maria Doctor, a second-year postgraduate resident at LV Prasad Eye Hospital. I'm hailing from Mumbai.
Shobh, how many people actually participated in the quiz?
Around 95 participants registered, and out of these are the 4 finalists.
Very good, very good. So all of you have done extremely well, national level. Very good.
The participant 2 is Dr. Nadna Bashir from Giridhar Institute, Kochi. Please introduce yourself.
Hello, I'm Nadna Bashir. I'm doing my final year DNB in Giridhar Institute, and I'm coming from Thrissur, Kerala.
Excellent. Participant 3 is Dr. S. Chandra Devi from RP Center, Ames, Delhi. Please introduce yourself.
Hello, I'm Dr. Chandra Devi. I'm doing my second year PG in Ames, Delhi.
Participant 4.
Where are you from?
I'm from Pondicherry. I'm from Pondicherry.
Okay.
Participant 4 is Dr. Adra Devraj from Jipmer, Pondicherry. Please introduce yourself.
Hello, I'm Dr. Adra Devraj. I'm doing my final year of PG in Jipmer, Pondicherry. I'm from Kerala, Kannur.
Oh, that's great. So we have introduced our finalists, and I think, yeah, the prizes are sponsored by Severa Labs. They have helped me with the prizes, and these are the general rules. You have to keep your audio and video on throughout. Our eagle-eyed judges will be looking at you all the time so that you don't do any hanky-panky, which obviously you won't do. Mute yourself unless you are answering the question. Okay. When you are asked to answer the question, you unmute yourself and answer. Log into Zoom on one device, and the second device used for buzzin.live. That is for the buzzer round alone. Organizers shall not be responsible for any technical glitches and the internet speed problems. And as always, this is not a democracy, it's a dictatorship, and I am the ruler. This master's decision is final. So,
I think Chandra Devi needs to put her video on.
Yeah, Chandra Devi has to come with the video on.
Please put the video on. Dr. Manju, if anything is there, you can inform me. I cannot actually see their screen.
You can also put your video on. It's okay.
Madhina says that her buzzer has stopped. I don't know what that means.
No, that is okay. Buzzer round will tackle when that happens. That's the second round. First round is not buzzer. Because I cannot see your videos when I'm playing the presentation. Dr. Manju?
Yeah, Prashop.
You can just look at them and tell me if there's any problem.
Yes.
Because I'm presenting, I cannot see the videos. All right, shall we go to the first round? Everyone ready? These are the rules. This is a clue round basically. There are no past questions, all direct. There are 40 points for the taking here. If you answer the question without any clues, you get all 40. You can ask for a maximum of 3 clues. If you ask for 1 clue, you get 30 points. And answer correctly, you get 30 points. If you ask for 2 clues and get it correct, you get 20 points. And after the 3rd clue, you get only 10 points. There are no negative marks. And you have only 1 attempt. Like if you don't ask for any clue and answer and it's wrong, then that question is gone from your hand. All right, is it clear? Then we'll move to participant 1. Dr. Maria, are you ready?
Yes, sir. I'm unable to see the slideshow if it's being shared.
Is that so? Can Dr. Manju confirm whether you cannot see the slideshow?
No, it is clear. I can see now.
You can see it, no?
Yes, now it's visible.
Okay, I'll go to the first question now. Dr. Maria?
Yes, sir, yeah.
What is the modern terminology for the condition dystrophia epithelialis corneae? You have 3 clues. If you know the answer, you can answer right.
Yeah, could you give me a clue, please?
Okay, this is your first clue. The photograph of a gentleman.
Clue 2.
Second clue. 20 points. I can tell you that this is an transmission electron microscopy picture. You may have to guess what those short forms mean. ABL, PNBL, PBL. Give you a clue. L stands for layer.
Yeah. Clue 3.
Want the 3rd clue?
Yeah.
This is the third. Or you can answer. You have no negative marks.
Fuchs dystrophy.
And that is correct. It is correct answer. 10 points to participant 1. This is Fuchs dystrophy. Initially, when Dr. Ernst Fuchs had described it, it was epithelial bullae that was happening. So he thought it was in the epithelium. But he was generous enough to accept that it may not be the epithelium. Further discoveries are made. So now we know it is not the epithelium that is involved, it is the endothelium that is involved. 10 points to participant 1, Dr. Mary.
Ernst Fuchs is from Austria, and he has to use credit a lot of ophthalmological discoveries. So if you can show that picture again, that picture may come multiple times. Ernst Fuchs.
Yeah, this is Dr. Ernst Fuchs.
Okay.
Right? I would appreciate if the other participants mute themselves when the question is being asked. Now the second question is to participant 2, Dr. Nadna. Are you ready?
Yes, sir.
Identify this legendary ophthalmologist for 40 points.
Sir, next clue.
Okay. The first clue. This is the original paper, landmark paper published by him. I obviously blanked out his name. Along with Arthur M. Silverstein, he has authored it. Transplantation and rejection of individual cell layers of the cornea. The pictures on that. Published very long.
Sir, the next clue.
Okay, the next clue is this. He was born in Shiraz, Iran in 1935, with fellowship at Wilmer Institute, Johns Hopkins. At his peak, he performed more corneal transplants than the top 5 transplant surgeons in USA combined. He was a doyen of transplantation and has a corneal line named after him, and recently passed away in New York. You have an answer?
Cordados.
So that is the correct answer. You get 20 points. You identified him correctly. It's Dr. Ali Asghar Khurdadost, an Iranian ophthalmologist. So the third clue that I was going to give, which would have been very obvious, that is, what is that?
Cordados line.
That is Cordados test line.
Rejection, yeah.
And due to endothelial rejection.
Yeah, correct. You get 20 points. Participant 2 gets 20 points, Manju.
Yes, yes.
So question is to participant 3. Participant 3 is? Participant 3 ready?
Yes.
Dr. Chandra Devi, this is your question. What is the claim to fame of Karl Brouwer of the Czech Republic?
Can I have the
clue? You want a clue?
Yes.
Okay, this is your first clue. On December 7th, 1905, Karl Brouwer, a 11-year-old boy, suffered a penetrating injury to both eyes with lodged iron metal foreign bodies and was brought to a clinic in Olomouc, Moravia, Czech Republic.
First corneal transplantation.
Hello.
You have 2 more clues, so think and answer.
Yes.
Anita ma'am, can you
He has
mute
undergone
yourself?
first eye.
Can you mute yourself, Anita ma'am? Because
Yes,
we can hear you speak.
Okay.
His eye was the first eye to be transplanted. Hello.
Can you say that answer again?
His eye was the first eye to be transplanted.
So he's the first recipient. What do you say?
No, donor. He is the first donor.
He's the first donor. That is absolutely the correct answer. Karl Brouwer was the first successful donor. Who did the transplant? You know this gentleman? Who did the first successful eye transplant in 1905?
Ism.
No, you already have your 30 marks. Don't worry.
Conrad Zim. Zim.
Yeah, that is Zim. Edward Conrad Zim is the correct answer. Alio Gloucester was the laborer who received the eyes. He had a chemical injury due to light. So in this round, yeah, 2 people have joined. Nadna has also joined. Waiting for Chandra Devi. Keep your page active in where you have logged in. that page active. Just waiting for Chandra Devi.
Can you repeat the code once?
359389.
Okay.
This is a simple buzzer. Whoever presses the buzzer first will get a chance to answer, and answer only when the quiz master asks you to. Don't blurt out immediately. I will tell you who's the first person who was buzzed. I have the device with me, and you get 20 points for the right answer and -5 for the wrong. So if you don't answer, the second person who answered, buzzed, will get the chance. Again, same points for the second person as well. Now you will see a locked written on your buzzer. Are you seeing all of you seeing that?
Yes.
I just unlocked it and I reset it. Can we do a trial run? Please press the buzzer. Okay, all of your buzzers have been registered. I'm resetting it now. Now don't buzz it. Don't buzz now. Now for the question only you have to buzz. Are you all ready? So
Yes,
here
sir.
comes the question. Here comes the question. Name this condition. We have 3 buzz players who have buzzed, and all 4 have buzzed now. Dr. Maria gets to answer first.
Crystalline keratopathy.
I need the full answer.
Infectious crystalline keratopathy.
That is correct. That Maria gets full points, 20 marks for Maria. Very well answered. What is it caused by?
Sometimes during graft rejection.
Is it graft rejection? Or which is the most common organism causing it? That is usually asked as a sub question. Okay, coagulase negative staphylococcus. Okay, I'm resetting your buzzers. Are the buzzers reset? 20 points to Maria. Anju.
Yes.
Buzzers are reset, all of you?
Yes.
Yes.
Okay, next question.
Right.
A patient underwent cataract surgery in a CAM setting and was lost to follow-up. What is the diagnosis? Look at the picture and give the diagnosis. We have one buzzer. So I'm guessing that only one person wants to answer. So nobody else gets the chance. Nadna and Maria have all 3
Sir.
of them. Oh, yeah. Nadna.
Band-shaped keratopathy.
No, that's the wrong answer. Nadna gets -5. Now Maria gets the chance to answer.
I had the same answer.
Huh?
I was going to answer band shape too.
So you're also saying band shape.
Yeah.
You get -5 as well. Chandra Devi.
Lipid dystrophy keratopathy.
That is also not the correct answer. All 3 get -5. Okay, so cataract surgery in a CAM setting. Post-op, what do you give? Antibiotics and steroids. Patient did not come for follow-up. No, Adra, you cannot answer now. Antibiotics and steroids. Antibiotics for a long time. What do you get? Which antibiotic is commonly given?
Deposition.
Yeah, that is correct. It's a ciprofloxacin deposits. Corneal deposits. Okay. So I'm resetting all your buzzers. So 3 people get -5. Anju noted?
Yes.
Except Adira, I think. All other 3 are -5. So next question. I'm resetting the buzzers again. What is the treatment for this condition? Look carefully. Question is, what is the treatment, not what the condition is. Okay, 3 people are buzzed. So Adira gets the chance. 4 are buzzed. Adira?
The topical steroids. So, case of Sansa Sahara.
Okay, that is the wrong answer. Adira gets a -5. Nadina?
So initially conservatively with the topical steroids, and if it's not improving, we have to lift the flap. And
what do you think it is?
It is an epithelial ingrowth after LASIK.
I will go to Maria.
Yes, epithelial ingrowth you usually just observe, or then later you lift the flap and irrigate the.
The picture is in front of you. You have to answer what you have to do.
What is the condition?
So the picture is in front of you. This is the patient.
I'd like to observe.
What do you do?
To observe the patient.
I'd like to give. I want to give you marks, but I cannot. I think we can give Nadina the marks.
Nadina.
Nadina can be given the marks. It is epithelial ingrowth.
So Nadina will be getting 20 marks.
Yes. Adira gets a -5.
Yes, yes, yeah.
And Maria also gets -5.
Okay.
Sorry, Maria does not get -5 because the question doesn't come to her if Nadina answers.
Okay.
Maria does not get any
zero
marks. Nadina gets it. It's epithelial ingrowth. It is significant enough. It's encroaching the pupillar area. You have to lift the flap and scrape it off. Steroids won't do the trick here. The steroids are helpful in another condition, which is it?
DLK.
Answer. That's answer Sara, DLK. Okay, are you ready? I'm resetting your buzzers. This is the fourth and final question in this round. What is the diagnosis? Look at the video also. I see the video play. Corneal condition. Okay, nobody else wants to buzz now, so more buzzers allowed. Adira can answer. Dr. Adira?
So it's Candida.
I didn't hear that. Can you say that again?
It's Candida, sir.
Candida. Candida is what you said. That's the wrong answer. -5. Maria?
Acanthamoeba.
No, that is also the wrong answer. -5. No, you cannot answer, Chandra Devi. The time is up. The answer is, you have to look at this. What is this called? That is a zoospore formation that is being demonstrated. 20. And look at the cornea. Can you see tentacle-like lesions extending from the main infiltrate? It's pythium or pythium keratitis. Okay. So I think all 4 answers are done. So we are done with the buzzer round. Anju, are you ready with the scores?
Just a minute.
Yeah.
Yeah, I think Dr. Maria got 20 points. Dr. Nadina got 35 points. It's total. And okay. Dr. Chandra Devi, 25 points. And Dr. Atira with -10 points.
There is still a lot of points to be made up. You can, whole situation can change in a matter of 1 round. So we are moving to round 3. I like to call it the differential scoring round. So no answering loudly in this round. You just have to WhatsApp your answers to me. Okay. Don't shout out. If you shout out, the other person gets the idea and you lose marks. Okay. There are 40 points to be taken. All 4 get it right, you get 10 points each. 3 get it right, 13.3 each. If 2 get it right, you get 20 points each. And if only 1 gets it right, she takes away all 40 points. And there are no negative marks, so feel free to answer. All right. So there's a time limit, what 10 or 15 seconds, after which you cannot send me. So send the answers right away. All right. This is the first question. Name this novel procedure. Carefully, there's a corneal topography involved in there. It's described by an Indian. Nadna has answered. I'll give you 10 more seconds. Chandra Devi has also answered. So I'm assuming the other two are not knowing. There are no negative marks. There are no negative marks. Okay. Yeah, we have three. I got three answers. Adira has not answered. So shall I assume that you are not answering? All right. I'm assuming that Adira is not answering, and the answer is cares. Discovered by whom? Those implants are not intact. They are what are they? They are actually corneal tissue, stromal tissue. Discovered by Dr. Susan Jacob.
Susan Jacob.
One of the later advancements in the field of cornea. It's called corneal allogenic intrastromal ring segments. No one has got it right, so no marks for anyone.
Okay.
So this is the next question. Identify the complication. It's an ASOCT picture, obviously. Think of what surgery has been performed. That is not important. The complication is what is important. Shown by the white arrow mark. Adira has answered. If you're not willing to answer, just say it now so that I can skip it. Devi is typing and question is simple. Identify the complication.
You should have a time limit, Prashop.
Yeah, okay. I think we will. I think that's it. No more answers will be taken. Dr. Chandra Devi alone has got it correct. It's a retroprosthetic membrane after Boston type 1 A probe. So Chandra Devi gets 40 marks.
Okay.
Yeah, please be fast in your answering. Henceforth. Okay, this is the corneal condition and name the stain used. I want the name of the stain. Okay, I got three answers. Yeah, I got all four answers. All four are correct. It is calcoflow white, and all of them get 10 points each. Well done.
Okay.
This was staining acanthamoeba. Okay, this is the next question. What is the diagnosis? That is the slit lamp picture, and the other one is not a slit lamp picture. It is a microscope on the diagnosis. So I'll give you some 10 seconds from now. I have two answers. Okay, that's it. I've got two answers. I'm locking it now. Three answers actually, but two are correct. Sorry, three answers. All four have answered, and three are correct. Dr.
Okay.
Maria, Dr. Chandra Devi, and Dr. Adira all have answered correctly. It is ocular cicatricial pemphigoid (OCP), mucous membrane pemphigoid. So three are correct. So 13.3 points to each. Maria, Chandra Devi, and Adira. No points to Nadna. 13.3 points. Is that clear, Manju?
Yes, yes.
Okay, with that, we come to the end of this round. And the next round is going to be rapid fire. Before that, I think we can have a look at the scores.
63 plus 23.
I'll explain the rules of the rapid fire. It is a 5 questions to each participant and 40 seconds in all.
23
question and
minus
answer.
10.
You can skip the questions and return to them if time permits. But once you answer the question, you cannot change the answer. 10 points for the correct and -5 for the wrong answer.
So can I tell the score now?
Yes, yes, ma'am. Please go.
Yeah, Dr. Maria scored 43.3 points. Dr. Nadina, 45 points. Dr. Chandra Devi, 88.3 points. And Dr. Adira, 13.3 points.
Yeah, still a lot of points to be scored in this round. I think you can do the catching up. The number 2, 3, and 4 are very close to each other. Okay. So the rapid fire will be asked to one person only. The others, please keep your Zoom on mute. So the participant 1, Dr. Maria, gets these questions now. Is Maria ready?
Yes, sir.
Okay. Anju, timer ready?
Yeah.
Just tell me when the time is over. All
Yeah.
right?
Can I? Yeah. Just tell me when should I start timer?
Yeah, just with the first question, you can start. When I start asking the first question, you can start.
Yes. Yes. Yes.
Interrupt me if your time is over. Okay, here we go.
Yeah. Yeah.
SARS-CoV-2 is a double-stranded DNA virus. True or false? Don't know, you can pass.
False. False.
False. MUT1 trial compared which 2 drugs?
Pass.
Pass. Topical medication that can cause cornea verticillata.
Amiodarone.
Which procedure is being performed here?
Neuratization. Corneal neuratization.
Okay. Identify the abnormality marked by the question mark.
Time is up.
Time is up. So,
can I complete? Absent corneal nerves.
What is the investigation?
Specular.
No, I cannot give you the marks for that. I will not give you a negative because you're partially right.
Confocal.
That should I give the mark for that? Film judge, if she is listening, I think I'll give you the marks.
I think you should give marks for that.
Yeah, yeah. Okay, I'll give the marks. SARS-CoV-2 is a RNA virus. It's not a DNA virus. It's a single-stranded RNA virus. MUT1 trial, you did not answer that.
So the first question 1, she gets 10 marks.
It's 10 points. 10 points.
Yeah.
Question 2, she gets no points.
Yes.
She passed that. It's natamycin versus voriconazole.
Yes.
Question 3, she answered wrong. It is the topical medication that I asked. It's Netafsudil. So she answered amiodarone. She gets -5 for the third.
Okay. Yeah.
Fourth question, neurotization. That's a brilliant answer. She gets 10 plus 10 for that.
Okay.
And the abnormality, I'll give her plus 10. It's a confocal microscopy with decreased basal nerve plexus density in HSV keratine. So plus 10 for that also. Is that clear?
Yes.
Total how many points, Panju?
She got 25 points.
25 points. Okay.
For this round.
For this round, yeah. Nice. So participant 2, Nadna, are you ready?
Yes, sir.
Anju, timer ready?
1 minute. Yeah.
Okay. Starting now. Primary mode of spread of COVID-19 is through fomites. True or false?
True.
Give an indication for oral acyclovir according to heads.
Linear endothelitis.
Levetiracetam is used for the treatment of
You
can pass if you want time.
Neurotrophic keratitis.
Name the surgery. Time.
Sir, next question, sir.
Name the investigation.
Time is up.
Topography.
Okay, so she's answered that. The first question was primary mode of spread. What is the primary mode of spread of COVID-19? You shouldn't be getting it wrong. Your sleep also, you should be getting it correct. This droplet transmission, not through fomites. Fomites is a secondary mode of transmission. Okay, that is -5 for that. She for given indication for oral acyclovir, she said endothelitis, which is wrong. -5 for that also. Second question. Third question, I think she passed. Not given answer. 0 for that. The surgery was descemetorrhexis without endothelial keratoplasty or DVEC, also known as DSO. No marks for that. And investigation, she said topography. It is not topography exactly. It is the corneal epithelial thickness mapping with ASOCT. So -5 for that also. 3 -5s, I think. Am I correct, Manju?
Yeah.
-15.
Yes, yes. -15 for her.
Yeah. Is the third participant ready?
Yes.
Okay,
Yes, I'm
Chandra
ready.
Devi, you are Manju ready? Quick timer.
Yeah, yeah, ready.
Okay, your time starts now. SARS-CoV-2 infection is less common in individuals less than 60 years of age. True or false?
False.
Expands cut.
Pass.
Senegermin was recently FDA approved for the treatment of
Pass.
DALC post-op 1. Identify the complication. A1. Right.
Pass.
Name the investigation. Want to attempt any past questions also? You can.
Up. Time is up.
Your time is up. I think she has answered the first question correct. SARS-CoV-2 infection is less common in individuals. It's false. The severity of infection is less common, not the infection. That stands for steroids in corneal ulcer trial. So +10 she gets for the first answer. Second question, no marks. Third question, Senegermin is approved for the treatment of neurotrophic keratitis. So no marks for that also. Dial post-op day 1, it's a double anterior chamber. No marks for that. And the investigation is anterior segment fluorescein angiography. Is a photograph taken by Watson in 1987. Okay, so she gets +10, I think. Manju, am I right?
Yes, yeah.
So coming to the last participant, Adira, are you ready? Manju, ready with timing?
Yes.
Adira, are you ready?
Yes, sir.
Okay, here you go. Your time starts now. Conjunctivitis can be the only presenting sign and symptom of COVID-19. True or false? Can't hear you.
True, sir.
Expand CLEC study.
Pass, sir.
Name the drugs which are shown potential to enhance endothelial cell proliferation.
Pass.
Identify the surgery being performed.
It is PDEC.
What is the finding?
PDEC. It's a medomography with the MGD. Meibomian
More specific finding.
Time is
there
up.
will be decrease.
You can say that answer completely.
Decrease in the number of the meibomian glands.
Yeah, that is okay. That's acceptable. So conjunctivitis can be only presenting sign and symptom. You said true. Get +10 marks for that. Expand CLEC study stands for collaborative longitudinal evaluation of keratoconus. No marks for that. You passed it. Drugs which are shown potential to enhance endothelial cell proliferation are Rho kinase inhibitors or ROCK inhibitors. You have not answered that, so no points. Surgery is actually DMEC guided by intraoperative OCT. You answered PDEC. I don't think I can give you marks for that. So -5 for that. And the finding is meibomian gland dropout on infrared meibography. You said decreased meibomian glands. I'll give you +10 for that.
So she got 15 for this round.
15 marks.
Yeah.
So that is about the final marks. Now, while Manju tallies the marks, I think she'll take some time. You can give your experience on the quiz, how it was.
You can close the screen, Prashop. Yeah, I think the postgraduate students who participated
can tell the score?
Can give their opinion. How we can improve on, further our Super Sunday and whether it is useful for all of you. You can give your opinion. All the PGs who have participated in this quiz program.
You can say your opinion. That's what sir said. Go ahead.
Yes, it was a good session, and even the interface was pretty convenient.
You like the interface?
Yeah, even the preliminary round, the quiz at the app that we had was pretty simple to use.
Good feedback then. Adira, Chandra Devi, Adna. What do you feel? Any comments to make?
No opinions. Manju, are you ready with the?
Manju is ready with the scores?
Yeah. Dr. Maria got 68.3 points.
You can announce from fourth runner-up.
Lowest to highest?
Yeah.
Yeah. Dr. Dr. Atira got 28.3 points. Then second runner-up, Dr. Nadina with 30 points. First runner-up, Dr. Maria with 68.3 points. And the winner is Dr. Chandra Devi with 98.3 points.
Oh, congratulations. The limitation of this platform is you don't get the loud claps, but I'm sure everybody is clapping in their minds. So the winner is Chandra Devi, and the runner-up is.
You are from RP Center, ma?
Yes, Dr. Maria.
Dr. Chandra Devi, you are from RP Center,
RP
right?
Center.
You're from. You said you're from Pondicherry.
Yes, I'm from Pondicherry.
Congratulations, Chandra Devi. Congratulations to you.
Congratulations. Yeah.
Good performance.
Thank you, sir.
So
I think a big clap to Dr. Prashop, who has done a phenomenal job in this quiz. We all know that he's a very avid quizzer. He has won various, even now he keeps on winning prizes in almost all the quiz competitions he participates in. And he's also very technology savvy. He introduced a lot of new things. And now we know how through Zoom we can conduct a quiz. So he is he's our own member, but on behalf of Cochin Ophthalmic Club, Prashop, a very, very special thanks to you for having done this quiz wonderfully well.
Thank you, sir. I just want to put a small message for our sponsors also regarding the prizes.
What is the prize?
Yeah, just sharing it. So as we know, the winners are Dr. Chandra Devi and Dr. Maria. And they get, this is the first prize, textbook on gems of ophthalmology in cornea and sclera by Dr. Nema et al. And the second prize is Ophthalmology Clinics 2 for postgraduates by Prafula Kumar Maharaj. And the prize are sponsored by Zivira Labs. So heartfelt thanks to them also.
Yeah, we should thank Zivira Labs also for their generous gesture. Yeah.
Dr. Gopal, any closing
Gopal,
comments?
please unmute.
So it is a long 4 hours. I hope a lot of people have benefited by the 4 hours of interaction. I think
Gopal, can you mention how many people participated in the YouTube live?
Yeah, so in the YouTube live, there are about 70 people who have seen this. Right now, there are about 40 participants.
Sir, your voice has gone. Your voice has gone.
Yeah, now can you hear me? Okay, one second.
The voice has gone. Number of YouTube participants we'll know after we stop actually. We just know how many are live now.
Can you hear me now? Can you
it's
hear
a little
me?
faint. If you're louder, you can be able to understand.
Yeah.
Hear you, but you can't see
Yeah.
you.
Yeah, there are about 70 participants totally in our YouTube. So 70 postgraduates must have seen this live. I think, yeah. And I thank all the cornea panelists.
Yes, sir, we can hear you. You can continue. Gopal, sir, we can hear you.
Look at the numbers.
Yeah. So I thank all the cornea participants in this who have basically sat through the 4 hours of meeting. And it was a wonderful day. I also learned a lot sitting here in a cornea session for 4 hours. And more than that, I would want to invite all the postgraduates, all the people for our program on the 20th and the 21st. It's an 18 hours of pan ophthalmology being 360-degree, which we are covering, right from cornea, glaucoma, retina, plastic, inflammation, cataract. All these things will be covered in 2 days in 6 sessions of 18 hours. That will be on the 20th and the 21st. Please block your dates for that. And please inform your co-postgraduates also for that. This will be a complete 360-degree ophthalmology roundup course called Ophthalmology Reboot. So thanking Zivera also. Over to you, Dr. Sai Kumar.
I think it was a wonderful 4 hours. I must confess that I did not hear the entire 4 hours, but part of almost all the talks I heard, and the quiz, obviously, I was there completely. So I think it was a wonderful session. And we are going to continue with the digital Super Sunday program. So in July, we are going to have a session on glaucoma. So we'll come up with more details as early as possible. Dr. Manju, who is here, is actually one of the main organizers of our July Super Sunday. It is going to be on glaucoma. It will be again around the same time, the first Sunday of July. But we'll come up with more and more information as the days goes by. But as Gopal said, we would like to invite all of you to the ophthalmology reboot, which is on 20th and 21st. So thank you all the speakers, and thanks to all the postgraduates for sitting through this on a Sunday evening. I hope you all benefited from this. Thank you very much.
Once again, congratulations to all the winners and all the finalists.